he is indeed a dynamic person who will be speaking to us today. Another very dear colleague and an equally big star, Dr. Harish Pillai, the dynamic CEO of Aster CMI, Aster India actually, and chair of the FICCI Medical Values Travel Committee. And, he was earlier the CEO of Egypt's biggest private tertiary healthcare hospital, As Salam International Hospital at Cairo for over 7 years. A very soft-spoken but effective leader, he was featured in the 2018 cover story of Healthcare Radius and conferred the Special Jury Award for the CEO of the Year at the first Business World Healthcare Hospital Summit in May 2019. Air Marshal Keshev Rao, the group medical head for Fortis Healthcare, retired from the Air Force after 38 years of colorful service, and he entered the world of corporate healthcare in 2014. He heads the medical strategy and operations and is senior vice president at the Fortis Healthcare, and a graduate of the Armed Forces Medical College, Pune, in March of 1976. He's a specialist in internal medicine and served with distinction in the armed forces for the 38 years that he was in it. He has caught on to the private healthcare way of life and is indeed a huge support to the medical community at Fortis and elsewhere. I now come to Dr. Sandeep Raja, who heads Max's Clinical Directorate, which is responsible for overseeing medical quality, clinical governance, clinical hiring and credentialing, research and training and analytics across 12 hospitals of Max, and currently operates more than 2,000 in North India with more than 2,000 clinicians. He has 23 years of experience in internal medicine and is director of the Institute of Internal Medicine at Max. He is an MD from Maulana Medical College, and he is also a graduate of the same college, completing his MRCP and joining Max in the year 2001. Another dear friend and colleague, Dr. Vinay Agarwal, able medical administrator, past president of the IMA, and managing director of Pushpanjali Medical Center, is a social activist and a luminous entrepreneur. A graduate also of Maulana Azad Medical College, he is a very senior person with 4 decades of medical leadership qualities. He has done pioneering work in not only healthcare management, but community services and resource mobilization. And as I said, he's past president of not only the IMA, but Confederation of the Medical Association of Asia and Oceania. And he is the founder, secretary general, and senior vice president of Pushpanjali Medical Center, and is the recipient of the coveted B.C. Roy National Award for Science. So as you can see, we have a huge galaxy, and let me not waste any more time. I would ask to go in alphabetical order, and I request Alok to start the proceedings. And then if we can go in the order of my introduction, that would be fine. Dr. Alok.
Thank you, sir. Thank you, Dr. Jairam. It's such a great pleasure to be here and you moderating the session. It's a great pleasure indeed. As the topic says that private healthcare in the forefront, from strategy to frontline trenches, proves the point. My topic, what you have been asked to talk about, the experiences and learnings. Very easy to talk about it for simple reason that nobody had any learning before that. So nobody had seen the virus. Virus was not known. Nobody was affected before December. So whatever we have, I'll say, is a learning. And what a learning. And not only learning, the way it has thrown all of us into the battle is just amazing. It feels like when we started that as if you're walking on a terra firma and one fine morning, the bottom disappeared and you fell in a trench with full of corona sharks hanging around you. That was the feeling we got, completely drowned, drenched in it. We thought it's coming. We thought it'll take some time. But the way it overwhelmed us, the way it went over us, and nobody was spared. Some of us took a very baby step in February, try to understand. And from there, the learning started. Suddenly, the sanitizers disappeared from the market. So first thing I did was to call my pharma guy, the one who runs the clinical pharma side, and told him, can you make a sanitizer at home? He looked at me as if he had seen a monkey. He said, what do you mean? I said, sanitizers are disappearing and what we are buying is very expensive. That time I thought sanitizer was expensive till I realized about rest of the expenses which are about to follow. So the learnings, if I can break it down into 3 components, it will be probably easier for us. That the very, very basic learning that something as fundamental as masking, social distances, and sanitization, which was a learning we just learned from whatever was being discussed or was coming on WhatsApp or the journals or people were sharing. Our learning started from there, and then we realized that those fundamentals are still staying with us. So our learning, what we had in February, is still with us today. And those are the strongest pillars of learning which we had. In between, we had to go through a huge infrastructural changes, which I'm sure many of my colleagues will talk about when they talk about their experience across the country, that the infrastructure changes were so varied. We never thought that something is negative pressure. You have to seal your area. People have to wear PPEs. How to procure the PPE? The first PPE which we bought was over 3,000 rupees, and it was not available when we asked around. So we learned that there is something known as PPE, which a normal doctor, and forget about doctor, forget about nurses, even the housekeeping, even the one who's serving food has to wear and serve. There's such a uniformity of changes which happened across. And the kind of infrastructure changes which we had to meet was a huge learning that you need to think separately and very, very independently only for this, what is happening to you now. So the way it came on a very basic and infrastructure was just mind-boggling. And what is great about it, the entire country, entire the private healthcare rose in unison and did all those changes. Somebody did early, somebody did later. But now, today, as we are talking about it, everybody is in the COVID war, and every one hospital, small or big, are contributing to corona care. And they all have made changes, not only the infrastructure, not only the basic changes, they also have made changes in their mindset of treating patients. So a lot of things have changed in last couple of months, in last about very, very basic fundamental. The medical changes, we did not know what is the right medicine. We had, those who are around 60, we had a very huge faith in hydroxychloroquine. We always had faith in hydroxychloroquine for some strange reasons, maybe the age, or we have eaten it so many times because we got malaria. We kept on taking it. But there was a support group which said it's very good. And then support group, some of my very senior consultant in critical care came back to me, said, sir, why are you promoting hydroxychloroquine, giving to everybody? It's not good, doesn't work, sir. Sir, you don't know, it doesn't work. I said, I don't know, but it has not harmed me. Then everybody came up. I never knew that QT interval is so critical for hydroxychloroquine till corona hit us very hard. Because we knew in our back of mind, but we never bothered, never asked anybody, never got his ECG done before treating a malaria. We just gave him chloroquine and hoped for him to get better. And they all got better. I don't remember in my lifetime, and I've been practicing medicine for the last 40 years, where anybody died of first dose of chloroquine. He never died. Very, very rarely, unless he had some other deficiency, which Anupam probably will be more relevant to him in children. But otherwise, and within few months, it came back that the hydroxychloroquine is very reliable, continue giving it. Same story happened with ivermectin. my senior critical care specialist came back to me and said, sir, don't give ivermectin. Why are you giving it, sir? The dose which is therapeutically effective is so huge that what you're giving is just a homeopathy medicine. Came back, now everybody is giving hydroxychloroquine, everybody is giving ivermectin routinely, alternatively, or as at one point of time. The steroids, we did not know when we started that steroids would play a role. And before steroids could start playing a role, what happened when we started getting into Corona war? There are very few centers which were operating to receive the Corona patient. Anybody who got COVID positive, he came running to the hospital. He never stayed at home. He didn't want to stay at home. Even if he had a room isolation, he never wanted to stay at home. We had a lot of opportunity in isolating him, treating him, looking at him. So when something happened, we jumped at him and made sure that he is a little better off. Now, off late, in last 2 months, because the fear is becoming kind of getting diluted, a lot of small nursing homes have opened up and they are holding the patient longer, and most of them, as we know, 80% patients go home. They are not very sick. Those 20% who are sick, they are also retained at those small places. So by the time they come to us, most of the patients are very sick. Our learning has been that the earlier we intervene, and with our new learning of role of steroids, how critical it is, the timing is important. Off-label medicines like CPT and all have been so important. Remdesivir has become so important, but the timing is very critical. Now, earlier we could time it well because patient was with us. Now, because patient is coming from outside, being retained in the small nursing homes or by independent individual doctors treating him in their own houses, patient houses, we are getting far more sicker patients. Just to give an example, we have got around 62 ventilators for COVID ward we have allotted. When we started 4 months back, 3 months back, we had hardly 10, 15 ventilators were running. Today, over 50 ventilators are running because we are only getting referred those patients who were at home or in small places. And the moment 80% went home, 20% got sicker, got pushed to us, and it was too late. We are running 8 ECMO. We suddenly realized just one disease, the spectrum is so varied. 92-year-old patient is asymptomatic, walks back home on 7th, 10th, 11th day. When we are not seeing any storm, we send him home. And 28-year-old who gets on ECMO and succumbs to the disease. Same patient, same age group, same comorbidity, same treatment given in the same circumstances. Some of them go home, some of them don't go home, and we have no clue why it is happening. So the learnings, as I was telling you in the beginning, has been round and round. Learning has been whatever was said about hydroxychloroquine has come back again, which was denied in between. Same thing, ivermectin. We have only 3-4 medicines available to us, and we are just playing with the steroids. So what has been the biggest learning of this pandemic is, first, that we need to be human, number one. Number two, there is no shortcut to being collaborative and participative. What we have seen, the role of government has been, if they were collaborative, they were a huge strength. If they were not collaborative, they turn out to be a very negative and hurt us in serving a larger part of the community. And also we have seen that this COVID has kept our non-COVID patients out of the hospital. Most of them are not coming, not because they are not well. They are not coming because they are very scared. They are very scared. And second, our people are not coming from distance because of transportation. These two reasons why we are not getting enough patients, non-COVID patients in the hospital, unless it's kind of emergency. Before I conclude, I would like to say that we do not have cancellation of healthcare problems. Anybody who's having chest pain will have to come for angiography and angioplasty and surgery. It's a matter of time. Anybody who's having gallbladder pain will have to come back. Anybody who has a hernia will have to come back. Lifestyle diseases will have to come back. People are living with 300 random blood sugar by staying at home, taking our cues verbally or on telemedicine and all that. So there would be huge surge of patients as the pandemic goes down. It will come down and settle down at a level, and then the non-COVID will start coming in. So we all will have to brace for another shock. That's what my sense is, and that's what we have learned so far in the pandemic. Thank you, sir. Over to you.
Thank you, Alok. Very interesting and it's an eye-opener, your sharing of your experience about how the disease progressed and the problems that you have faced, which I'm sure is duplicated across the country in one or more ways. Thank you indeed for exposing your experience in this difficult area. And we would ask all the listeners to send in their questions, if any, to each of the speakers via chat, and we'll address them at the end of the session. Thanks indeed, Anu. Over to Anupam.
Thank you so much, Dr. Nandkumar, Aarti, Alok, Dr. Puri, and the organizing team at FICCI for this very kind invitation. I'm just going to start sharing my slides. Are my slides visible?
Yes.
Great. Thank you very much. Good afternoon to everyone. What I've been asked to cover in 10 minutes is navigating the response to COVID-19 across 16 states. Just to remind everyone, 17.7% of humanity lives in India. Health is a state subject, and that's why I want to highlight that we have 28 states, 9 union territories. And not only is health a state subject, but also within each state, there can be a fair amount of flexibility that each district magistrate has, and we have 739 districts in the country. This is what the Apollo network looks like. We have a presence when we just look at our hospitals, our clinics, our daycare centers, our birthing centers across 16 states. I'm not taking into account our pharmacies and diagnostics because then it goes to more than 20 states. When the COVID pandemic started, we saw that there was a flurry of activity and we saw a lot of advisories and updates coming in, and we needed to brace ourselves because we knew there would be a lot of changes. And because we have a network across 16 states, we had to every day look at what was happening in that particular state. And a fair amount of time and resources were assigned to this very important activity. Just to give you a sense, there have been 137 advisories from different departments, ministries pertaining to hospitals. There have been 73 about travel, which is very relevant when you have patients coming from outside the state. What is very relevant is the rules that apply to citizens, and that means all our hospital staff, relatives of patients, and so on. There were 19 advisories on training, and for how to manage employees, 15. So looking at the larger picture, looking at creating a pan-India 360-degree program, we developed Project Quach. This was an integrated comprehensive plan that looked at how is it that we can pass on the right information, how is it that we can educate the public, how do we scale up, whether it was in terms of diagnostics, beds, ICU, what could we do with stay-I, which means staying outside the hospital but under supervision, and what is it that we could do in terms of treatment, and this meant both in hospital and virtually, and what is it that we could do in terms of providing diagnostics and medication closer to home. So we knew that a project or an initiative of such a large scale would require dedicated teams, not one team. So we created several teams. So there was a lab team, again, pan-India with input from hospitals across, a clinical protocol team, infection control team, an operations team, because there was a lot that we needed to do in terms of operations, procurement, compliance, quality, communication within the hospital, communication outside, strengthening the mortality review because we had already heard the kind of mortality figures that were coming out of France and Spain and Italy. And of course, what is it that we could learn and how is it that we could contribute to research? So we had several of these teams that were constituted, and they were constituted in a matter of a couple of days. We realized very early that we need each other. I mean, if there was one situation where we couldn't have done it alone, which means the clinicians couldn't have done it without the support of everyone else. Well, it was the COVID-19 approach. We also needed to reach out to everyone. So it wasn't just about, yes, we want to work together, but how is it that we work together? I mean, you couldn't travel. So how is it that we could actually work together, learn from each other, and be connected with each other 24/7? So given the fact that we are so digitally connected these days, we started using our IT capability to connect, and we've had all the medical directors, and we are talking about here 73 hospitals. So to connect with 73 different individuals on a regular basis, have a weekly review in terms of policies when it came to at the level of the medical directors, but also at the level of all the other teams that I just mentioned. So looking at education and awareness at the community, we decided, because there was a lot of panic and people didn't know whether they have or they are at risk of getting the SARS-CoV-2 virus infection or not, we developed a coronavirus risk scan, which is an artificial intelligence powered self-assessment tool. And 15.7 million people have downloaded this tool. We created a 24/7 COVID helpline. We made sure that the information that was provided was relevant to the state the patient was from. We reached out to social media for information and education, and we've had about 70 million views for this initiative. We started looking at virtual healthcare. So we have Apollo 24/7, which is our digital platform for consultation at home. We have a network of 3,800 pharmacies that delivers medicine at home. We have a very large diagnostic program that provides facilities for collecting samples at home. We started virtual rehab, virtual dietetics, and because of the issue with stress, we also started virtual counseling. We made sure that we strengthened our ambulance team and that our protocol ensured that medicines were delivered quickly. Well, there was, as we all know, one lab that had the ability to test in the country in March. So we started with our big hospitals and then scaled up to 16 labs across the country with the ability to do RT-PCR, CBNAT or TrueNAT. And then in the states where antigen testing was allowed, we started antigen testing and antibody testing. As we were building capacity, we knew that we needed to standardize everything. So we created the Red Book. The current version of the Red Book is version 12, and version 13 comes out on Thursday. This is a very comprehensive Red Book that looks at every single aspect that one needs to know for staff across the board, from clinicians to non-clinicians, on how to manage the facility and patients with COVID-19. It's been said by Dr. Jairam that we've never seen such a knowledge explosion. So as of yesterday, there were 58,155 papers on COVID-19 published on PubMed. On treatment alone, there are more than 21,000 papers. There are more than 3,300 papers published from India. And on treatment alone in India, there are 102. So we needed to review data if we were to say that the treatment that we are providing is contemporary. And we, through the clinical core group, have revised our protocol 30 times. The 31st version is going to come out on Saturday. We do this weekly, but of course, when data from the recovery trial became available from the United Kingdom, we had to change our protocol to introduce steroids within 24 hours. And then that week, we changed our protocol twice. We've been looking at how to publish and share knowledge. So we've now published 88 papers on COVID-19. We wanted to be a part of clinical trials. So the trials that we've been a part of, tocilizumab, recombinant BCGA, plasma, the Solidarity trial, Favipiravir trial, Nimofustat trial, the HOPE study, Selenium, and there are another 4 in the pipeline. Because the state health authorities and the ministry and ICMR were very particular about reports that needed to be submitted on a daily basis, we made sure that there was a compliance team that provided all the information in the format that was mandatory. We have an existing Apollo quality program in place that looks at handovers. This became even more important because there were no family members. So we strengthened the clinical handovers between nurse, doctor, doctor. We have been using AQP IPSGs for more than a decade. And that again is very important because again, you have no relatives with the patient now. Surgical care, very relevant if you're actually going to take in patients in a COVID environment where there's a degree of worry that families have, and if, God forbid, you have to take someone in for life-saving surgery if he or she has COVID, of course, medication, safety, and very important to standardize medical records. We also have an Apollo mortality review that we established 15 years ago, and we wanted to make sure that this fits in very well with COVID reviews, and we've been reviewing every week, every single mortality to see what is it that we could learn from every single mortality. So as of today, 35 out of our 73 hospitals have COVID patients. We've blocked 2,300 beds. The total number of patients that we've treated are, till yesterday night, 33,260, and the total number of tests that we have performed are 1,79,914. One of the things that COVID did was it broke barriers. It broke the silos in which we functioned. We broke the geographical, the time zone barriers, and the Global Indian Physician COVID-19 Collaborative was established on 11th of April. We've had 14 sessions, and we've had clinicians from more than 40 countries join. Not only have we discussed COVID, we've discussed different aspects of clinical management, vaccination, other strategies, patient safety, but we've also looked at how is it that we can benefit from spirituality. So we've had Sister Shivani address us, Sadhguru, Sri Sri, and His Holiness the Dalai Lama. And for the Dalai Lama session, we had 1 million views. So I think what COVID has done is brought us together. When the Indian Air Force showered us with the petals that uplifted all of us, we reciprocated, respecting and acknowledging the contribution of everyone that has worked towards safeguarding our country and helping us handle the COVID-19 pandemic. We strongly believe we can, we must, and we will. And I think the coming together of the public sector and the private sector and different organizations within the private sector clearly has demonstrated how we can, despite all the odds, overcome the challenges. Thank you very much. Jai Hind.
Thank you, Anupam, for an eloquent exposition of how you manage this across so many states. Deeply appreciate the coordinated actions and functions, as well as the formation of teams, which is so important in ensuring that the same protocols and management occurs in all the centers. I'm sure this experience would have enriched your knowledge, abilities, and also helped to coordinate actions and people in more than one way. Appreciate your comments. And I would now ask Harish to speak to us.
Thank you, Dr. Jairam. May I request the FICCI team to upload my slides, please? So I'll be talking primarily about how do we look after our most precious assets, that's mainly the healthcare workers. And like Alok mentioned and Anupam also, this is so critical in the midst of a pandemic. In the early days, some of us had lots of challenges, like in the case of my institution, Aster, the only blessing in disguise, I would say, was some of our hospitals in Kerala had already dealt with the Nipah outbreak, which took place in 2018. And the second arrival of Nipah, the first index patient was in my hospital in Kochi. So there was a kind of an institutional memory. And as we all know, Nipah is in terms of the severity and fatality is much more than COVID-19. So there were some important lessons which we could transmit across our network in 5 states. Next slide, please. So I'll be quickly touching upon these various. Can we go to the next slide? Yeah, so I'll be mainly talking about 2 important aspects, the critical role by the employee and the employer, and then we'll jump into the core team, mainly the medical workers, the few of the important lessons, what we need to talk about them. Next slide, please. Can we go to the next slide? Yeah. So typically after when the Prime Minister was talking about the first Janta curfew in March, in the middle of March, and we were all looking at lockdown in terms of a new normal. So we were looking at reaching out to our workforce wherever they were located to tell them about a much higher degree of consciousness and hygiene practices what they're normally used to. Typically in a society, we would expect that healthcare workers traditionally would have this as a default mode, that they are much more sensitive to hygiene practices than the rest of the community. But COVID-19 necessitated that they have to really upskill even those basic standards. So we are now referring to something called an ethical hygiene standards in the workplace, and how we can really walk the talk and become ambassadors, so-called role ambassadors for the rest of society. Next slide. So basically it takes two to tango. There are specific responsibilities for the employee and that for the employer. So I'll start with the responsibilities of the employee. Next slide. So I would like to categorize it into three segments. One is before you come to work, at work, and after work. I mean, clearly the at work component is, I would say, is relatively easier because it's within our control, within our environment. But before work and after work is a bit of a challenge. And we don't want to be, and we all have seen those news stories in April, in May, where a lot of residents associations across India had a sort of fear factor of having healthcare workers, whether doctors, nurses, paramedical staff residing in in apartments or residential colonies. There was all these kind of fear was mainly because of ignorance and lack of awareness. And there were unfortunate incidences where healthcare workers were targeted because they felt that these could be maybe some kind of a locus point for fresh transmission into their domestic community. So this is what we were trying to avoid. Next slide. So when we look at before work, clearly we were basically talking about how to wear a mask. Sometimes even among all of us who are running hospitals or in the midst of healthcare, we think wearing a mask is such a simple task, but there's a technique involved. And how do you wear the mask is something important. Then travel protocol, whether you come in your own private vehicle or once public transportation was permitted across India, how do you use public transportation? And of course, the mantra of safety is hand hygiene. And how do you really look at that? Next slide. So when you talk about the key responsibilities of employees at work, we are asking each employee to be a sentinel of good habits. One is greeting protocol. The Indian Namaste, the bedrock of our tradition, has become a global phenomenon thanks to COVID-19. So greeting protocols, when we talk about meeting protocols, as far as possible, we try to meet virtually. But then if there is a physical requirement for a meeting, then of course, there are certain standards to be followed. Seating protocols, we have to ensure that, especially the biggest challenge is your cafeteria habits or a tea break or a coffee break. That's when this cultural and the psychological need to to break the social distancing norm and get close to one another, and that could be a risk factor. So the seating protocols, the washroom etiquette, public area behaviors, and also any other safety parameters we need to be conscious about. Next slide. So after work, when we talk about is, you need to ensure that you continue to wash hands wherever you're deployed in the hospital, whether it's in a clinical setting or a non-clinical setting. But as a protocol, when you're saying that, okay, this is the time when your shift is getting over and you're planning to go home, you need to wash hands before you leave from work. Leave your footwear outside your home. So you need to create a zone. This is also a good habit that to also educate your own family members that don't carry your footwear inside your homes. And the clothes what you wear in your workplace, you need to put it away for washing and definitely have a shower. Next one. There are also key responsibilities for the employer. Next one. So this responsibilities can be in terms of an ergonomic gold standard. If you are in a non-clinical zone or your seating area, or even in a clinical zone where healthcare workers are deployed, how do you create a safe working environment? In terms, it can't be like before. Your office design has to be completely redesigned. And your housekeeping operations, we all know that in a hospital, You have the hot zones, which is basically acute care, your OT zones, and your regular non-critical zones where the housekeeping standards are a bit different. But that entire edifice of housekeeping operations need to be legged up in a significant manner. And then we have to also talk about the returning workforce post the COVID lockdown. And this was basically, when we reflect back, the first phase of lockdown across India. This was something from a protocol point of view, hospitals across India had to put their mind towards. Next slide. So when we talked about the ergonomic gold standards, the area per person, assess what exactly is your critical staff who needs to be deployed within the hospital, and is it possible for some of them or many of them to work from home, primarily from the non-clinical area. And if at all they come to the workplace, how do you ensure that there is a proper spacing between the workstations in order to maintain the social distancing norm? We need to ensure that clean water supply is available across the hospital. And of course, the most often, when in the old days, let's say old days, what I'm talking about before COVID, BC, we perhaps never paid attention to the engineering teams in terms of the air quality. Yes, air quality as a subject matter was debated actively in terms of the operating room, the ICUs, like Dr. Jairam and Alok mentioned about negative pressure room, that those areas definitely we looked at it. But generally as an environment, did we really focus on air quality? So this is very important to ensure proper ventilation, maintaining appropriate temperature in all rooms. I mean, we have noticed several WHO press conferences where they really talked about the aerosol effect of COVID-19 and the risk of getting an infection if you don't wear your mask properly. So clearly it's an airborne challenge which air quality within the premises need to really focus upon. Next one. So in terms of housekeeping operations, basically increase the cleaning cycles and the intervals. You need to restock essentials like liquid soap, the hand rub, the tissue papers, increasing the sanitizing of all the high touch surfaces. And this is something, it has to be like a default mode for all healthcare workers. We need to educate them the high risk areas, whether it's the doorknob, the staircase railing, in a patient's room, maybe the patient's bed railing. So these are the areas which requires increased sanitizing. And the healthcare, the housekeeping staff also need to have a certain checklist, and we need to reinforce by increasing their training protocols to pay special attention to these high touch surfaces. Next slide. So when we talk about the workforce which is coming back after a lockdown, the first step is to implement staff entry point control measures to check temperature of everyone, whether you're a clinician or you are a non-healthcare worker. Everyone's temperature is monitored. Then you also check and provide appropriate PPE and disposal bins within the area when they come to the hospital. Provide hand rub solutions and circumvent the biometric attendance capture. In the before COVID period, in many hospitals, the fingerprint was captured, and obviously this is something which should not be practiced and is avoided. So many hospitals have moved away from the fingerprint to basically an iris scan. So these are simple measures. Second aspect is to operationalize more transportation frequency to avoid crowding in for example the staff buses, to ensure that there is adequate space between the seats within the bus. These are, and also the sanitization protocols for transportation. The third part is enforcing social distances, like we spoke before. If you ask me, a red zone within a hospital is clearly a cafeteria. That is something which we have seen, and it's very interesting that when we look at the data of hospitals where staff have got infected, it shows that it is not the staff who are deployed in the COVID areas who are at risk for infection, because clearly they're all practicing the protocols to the last T. But it's actually staff in the non-COVID areas, and for them the breach happens in areas such as a cafeteria or a coffee zone or a tea zone. This is where the risk is much more. Implement department-wise staggered usage of the cafeteria. That's where the HR department need to really step up in a very big way. And also the lockers. How exactly, what is the usage of the lockers, how many staff go to the locker area. So this is also a zone to be focused in. The last component here is to introduce flexible policies such as work from home. The HR department need to have some protocols about reimbursement of your Wi-Fi, for example, broadband. In India, we have this big challenge of reliable power supply. So UPS, one-time capex investment for employees who are working from home, maybe even hardware, laptops, or even desktops to be shifted from the hospital premises to a home zone. So these are the areas where the hospital HR department really need to focus on. The deployment ratio, so there is no staff burnout. Some of my colleagues earlier spoke about the mental health issue of healthcare workers. How do you ensure that the COVID duty is planned in such a manner that they don't get stressed out, both physically as well as emotionally? Rest of the aspects we talked about, the protocols within the hospital, and any new staff who's hired for the first time need to go through these onboarding protocols. Next slide. So now the last component is clearly the clinical team. So the word which Dr. Anupam talked about, Kavach, you could use the concept of Kavach within a hospital for healthcare workers as a shield. Next one. So here we will talk about initially risk assessment primarily for aerosol generating procedures on the right side and not non-aerosol generating procedures. Both sides you can have the type of eye protection, whether it's goggles or a face shield, the surgical mask in a non-aerosol generating area versus an N95 for aerosol generating. Within a hospital typically has the chief of medical services or the medical director, the infection control officer, and the HR head. You use standard protocols to assess the risk. There is a WHO guideline, there's a Ministry of Health guideline. You can have an interview witness or a PPE buddy. And if it's a high risk, then you classify that, or it's a low risk. And then you have to talk about if it's a low risk person in terms of healthcare worker exposure, activities that should be, like, for example, not unmasking, and the quarantine period in terms of exposure. And if you're in a high risk zone, what is the protocols to be followed? Next one. Next slide, please. Is about the patient attender management. Now, if we know that the patient attender is already exposed to a suspected or a known COVID patient, then it requires certain protocols that we need to identify that as a primary contact. How do we ensure quarantine methods at home? Protocols using teleconsultations. If home quarantine is not possible, could they be put into a COVID care center? So these are the issues which the team needs to look at. Next one. Now, if you're talking about a usual patient attender with absolutely no symptoms, then we need to follow the principle of educating them about masking and hand hygiene, maintaining social distancing and ventilation in the areas which I mentioned before, ensure social distancing and masking in all the waiting areas, and lastly, inquire every day about whether they are having new symptoms. So these are the things which we need to focus on. Next one. So the basic protection is it's just basically a summary that all areas where healthcare workers are interacting with patients or their attenders, whether it's in the outpatient areas, counseling areas, registration areas, we need to ensure adequate and appropriate usage of PPEs, not only by the healthcare workers, but for all people coming into a healthcare environment, and monitor compliance regularly. Next one. So the other aspect is, this is something which Alok also talked about, that there is also a growing pent-up demand for non-COVID cases. Now that the lockdowns have been eased across India, a lot of patients, especially surgical patients, cardiac patients are coming up. In spite of, they do have a fear, but it's also the responsibility of hospitals to ensure that these new subset of patients are not exposed within a healthcare environment and they do not get COVID-19. So we need to follow specific protocols where they are concerned. Next one. So to conclude, the main success of preventive measures will depend upon following all the protocols. Please understand that even though vaccine is available, or it's supposed to be available by Q4 or Q1 of next financial year, none of us know about its effectiveness or efficacy. So the only thing which can help us is this basic things about, basic mask, social distancing, hand hygiene. So these basic things, if all healthcare workers do it diligently, then we can really preserve and conserve our workforce for the greater need of the community. Thank you so much. Over to you, Dr. Jairam.
Thank you, Harish. Thank you so much for a very elaborate and comprehensive talk on healthcare professionals and in general, and so many other aspects that you mentioned so aptly. I think one of the areas that all of us understand and appreciate is the fact that we are short of healthcare workers, which means that we have to take care of the number that we have. At this point in time, humanity tells us that we need to care for them because they are like every other human being. They need to be taken care of. But at the same time, it is also fair to say that depleting an already depleted workforce will not allow us to combat this virus in the manner that is appropriate. Harish has very clearly outlined all that is required in terms of safeguarding this task force, as also another important aspect, which is the attenders of patients who may be exposed. One area that others may not, lay so much of emphasis. Although this is not in the context, I wonder whether we as healthcare providers and healthcare professionals who serve a large part of the country should also take it upon ourselves to educate the general public on the three cardinal principles. Not following that is one of the reasons why our epidemic continues to surge and remain high. And I do hope that greater knowledge amongst not healthcare professionals, but the lay public will help us alleviate that. With those words, let me go on to thanking Harish and then requesting Air Marshal to speak to us.
Is my screen visible?
Yes, it is.
Well, thank you, Dr. Jairam, for the introduction. And since there have been three wonderful talks just before mine, there will be a little bit of overlap, but I'll try and give a different spin to what has already been said. So while the pandemic unfolded, we at Fortis Healthcare, working shoulder to shoulder with the state and central governments, unraveled some of the mysteries of this pandemic, our own innovation and enterprise. I'm going to just touch on 4 of these focus areas where we had to keep adapting as the goalposts kept shifting. Information and communication, clinicians in governance, our preparedness, and procurement. We were all told that fever, cough, and breathlessness are the cardinal symptoms of COVID-19. And then it became that you could have stomach upsets, or you could have diarrhea, and then it was lack of smell or lack of taste. The symptoms kept changing. And then elderly came in with just obtundation and nothing else. Some came with acute myocardial infarction, some came with strokes, and then there was acute kidney injury. At one point, we were told that it comes only from surfaces. So we swabbed everything in sight. We bought articles and we kept them in our car dickies for 3 days. We scrubbed our vegetables. And then they said, no, it's aerosols. So we put on masks and we've kept those masks on 24/7 for the last 6 months. I've just taken my mask off for this talk, if I may. We were told that there was brand new medicines come out, which were wonder drugs, only to be shot down the next day. So ladies and gentlemen, the sort of information we got at the start of this pandemic was something like these famous 6 blind men of Hindustan who went to see an elephant would probably have given us. And the anecdotal information at the start quickly erupted into an infodemic. And the first thing we did at Fortis Healthcare, something like what Anupam talked about, was to set up this Fortis Information Task Force. And every single day, this task force looked at the sites of the ministries, the ICMR, the WHO, the print media, and of course, all our very, very active WhatsApp groups. Took all the information from there, separated the grain from the chaff, collated this information, disseminated only reliable and relevant information, authenticated by subject matter experts. We call this Fortis recycled information to formulate our various guidelines and advisories. In fact, as the pandemic continued, our repository, in a lighter vein, we compared to the Mahabharata, when we said, and I quote, that what is here can be found elsewhere, but what is not here can be found nowhere. So thorough did we try and keep this repository of ours. Now, in keeping with our continuous, extensive, real-time exchange of information with our hospitals, I'll just flash a couple of dashboards here. One dashboard which shows us the number of patients we have treated, COVID positive cases, and it comes down to 16,444 cases had been treated since on the 25th of September. And on date, there were 1,391 patients treated across our hospitals. And this one dashboard also tells you how many of them and how sick they were in the different hospitals. And then we had to look very carefully, as everyone has been saying now, about the greatest resource of all, and that's our healthcare workers. So we looked at this dashboard we had. It shows us that from the start, 1,681 health workers have got infected. That's almost 10% of our workforce. And on any one day, 451 workers are currently positive, of which 92 are doctors and 260 are nurses. So ladies and gentlemen, at Fortis, we've always said that our clinicians are our strength, our raison d'etre, if I may say that. And so we worked out a process by which the clinicians themselves laid out strategy and then enforced the implementation of strategy in the trenches. It was a bottom-up sort of a system and not a top-down type of a diktat. All of us who are clinicians who have turned administrators know that if the clinicians themselves make strategy, it's easy to follow. But it's a top-down diktat, there's often a bit of a pushback, especially when you tread on clinical space. And then using the very popular and very active platforms that are there today, like Microsoft Teams or Zoom, etc., we set up these specialty forums. 14 specialty forums across our hospitals, and these specialists actually looked at the protocols and SOPs of their specialty. We just couldn't have done that centrally. And they had their fortnightly meetings where they did so. We also have this Fortis Medical Council, which is an apex body of the topmost clinicians, eminent clinicians, doyens in their field from across the country. And do you know, they met every week. Every single week, they met and reviewed what had happened in the previous week and set down targets and goals for what we are going to do in the next week. And therefore, at Fortis, we said that our pandemic-related activity is clinician-led. It is not corporate-led. And the collective wisdom of our clinicians ensured that measured, well-researched, authenticated steps were taken to combat the challenges of the pandemic. Preparedness. We had an advantage here over all the others in our country because our sister hospitals of IHH in Singapore and Malaysia had actually been affected by the onslaught a few months before us. And therefore, as early as the 15th of January, we got this first set of clues from them and the first write-up from them, which we were very easily able to incorporate. And within a week, we sent out our first advisory. By the 30th of January, we had set up flu clinics in all our hospitals. We had made out our forecasting of PPEs by the 15th of February. And on the 28th of February, when we got our first case, we were already well prepared. But of course, as has been said before, and as all of us know, the scene kept changing. The ICMR strategy on testing changed, and new drugs kept coming out. So we had to keep on changing our protocols, like has been said before. We had to keep doing the same during the course of the pandemic. In fact, 2 of our hospitals became exclusive COVID hospitals, and therefore the entire strategy in those hospitals had to be different from what we call the rest of our hybrid hospitals. But I'd like to stress that towards the end, when the real deluge came across Maharashtra, Karnataka, NCR, and now even Punjab, we really had to look back at our main resource, at our workforce. And we had to look into our workforce, and we had to see how we had to redeploy them, and we had to look back at workforce safety and on our workforce incentives. And lastly, when I look at this on this slide, I am the eternal optimist. So I stick my neck out to suggest that today, for the last 10 days, when recoveries have become more than fresh cases, and the R value has fallen below 1, have we reached in our country the inflection point? This is an absolutely shocking statement I'm making here. When you look at this snippet from Medscape News, which said that an 8-nation feedback study for doctors who had been treating COVID-19 patients, a considerable percentage of the doctors had sometimes, often, or always attended patients without proper PPEs. This was as much as 67% in Spain, 45% in France, coming down to as much as 23% in the US. Now, ladies and gentlemen, I don't think we had this problem at Fortis, and probably not in India at all. One of the things we did, of course, was to try to forecast our requirement of PPE. Now, honestly, at the start, that was like flying a plane that is being manufactured as you fly it. But we were able to get some sort of an idea based upon the number of beds we had. And obviously, it wasn't a very simple sort of a calculation, like 1 ventilated patient, 1 nurse, or non-ventilated patient, 1 to 2. It wasn't like that. It was much tougher, but we went to get through it. And we looked at different scenarios with 50, 100, and 200% occupancy. We followed the ICMR protocol for PPE, and we were able to get some sort of an idea. The PPE production in our country was zero. Before no PPE was produced in India before COVID started, and it went up to 4.5 lakhs a day by May. And today there are, if you look at CITRA or you look at DRDO, there are 1,800 agencies that are authorized to produce PPE, and they do so of PPE of good quality. Another little nugget of information I'll give you, and that is about medical grade oxygen. 750 medical tons of oxygen was what was produced before COVID. Today, we produce 3,000 tons. Another 2,000 can be added on if required from industrial grade. And I'm told that on the 5th of April, when those producing industrial grade oxygen came to the government of India and asked them for permission to shift to medical grade oxygen, do you know that the license was given to them in just 2 working days? We have to be proud of our country, ladies and gentlemen, and these slides show whether it was N95 masks, whether it was PPE, or whether it was hand sanitizers. The prices haven't risen at all. In fact, they've dropped, and there has been no scarcity of this PPE as we had thought or expected at the start. Of course, we did ourselves a favor in Fortis by reusing N95 masks. We use the UV germicidal irradiation in all our Bangalore units, one central place, and we sent the masks all, repaired masks all over. Plasma decontamination, that is frightfully expensive. And we have our hot air oven, which is used in the NCR. And of course, the AIMS system of laying off was used in others. I've come to the end of my short presentation. I thought I'll just highlight a few points where we did things differently and successfully. I'd like you to spend with me just a few moments in homage, to pay homage to the 4 healthcare workers who made the ultimate sacrifice and sacrificed their lives in treatment of COVID patients. Thank you.
Marshal Keshev Rao, fantastic. And thank you so much for enriching us with the experience that you've had. which is indeed something that we should chronicle and make available for future reference. Because as I said, this is not the only pandemic, and there'll be more to follow. And the experiences that not only you, but all the other speakers have shared with us will be of immense import for those who have to handle this in the future. And let they be more prepared than we have been at this point in time. Thank you indeed, sir, for an excellent exposition.
Thank you.
I would now ask Dr. Budhiraj to present.
Thank you, sir. I would like to start off by thanking.
Your voice is very faint, Doctor. You'll have to speak up a little.
Yeah, is it audible now?
Yes.
Yeah. So I would like to start off by thanking FICCI, Dr. Jayaram, Dr. Aarti to give me an opportunity to speak on this forum. Can I request the FICCI organizers to have the slide on screen? So I've been asked to speak on the clinical outcomes and presentations of a set of patients we have treated at Max. So we have a data of over 11,000 cases which have passed through our systems, and I'll showcase the outcomes and what our learnings have been over the last 6 months. Next slide, please. So as most of the speakers have said, we started off by creating clinical SOPs, and these were not only restricted to the treatment protocols, but also very importantly, an audit checkpoint. So we created a list of over 150 audit checkpoints to ensure compliance of various policies which were collated in our handbook, which were taken from the guidelines as rolled by Government of India and the state government periodically. And to ensure implementation, of course, a task force was put in place, which included people from the clinical side, the nursing side, and of course, the technicians and the medical admin staff and the medical quality staff. We also put in place at the same time the SOPs and protocols for home management of mild and early symptomatic cases. Can I have the next slide, please? So this has been spoken about earlier also. The various guidelines which evolved over the period of 6 months period, which incorporated various modifications and changes by the Government of India, by the Ministry of Health of State, and of course, as and when the new and experimental therapies came in, whether they were EUA approval or off-label indication. So we periodically kept upgrading or updating our protocols. Next slide, please. And of course, this has also been spoken about, focus on communication, how to continue the non-COVID services while maintaining COVID patients in most of the hospitals, how to handle the surge capacity, essential support services to be maintained, HR management, infection control practices, and of course, laboratory augmentation to cater to the increasing demand of newly introduced tests for COVID. Next slide, please. So I'll now come to the main part of the presentation, which is the clinical numbers and the outcomes of the patients. So if you see, we admitted our first patient on 30th of March. And since then, till date, we have handled about over 11,000 cases. We are mainly centered around the north part of India, NCR. We have 3 hospitals in Punjab and Uttarakhand and 1 in Maharashtra. So the basic load for us in terms of patients is from NCR, and we have had over 11,000 cases treated so far. So I hope I'm audible.
Yes.
Okay, thank you. Can I have the next slide, please? So this slide essentially shows the number of recovered cases out of the active admissions. So if we have recovered till date about 9,000 plus, we have had 682 patients who could not make it, and presently over 900 patients who are still active in the system. Next slide, please. So this slide beautifully shows, and this is a reflection of the situation in NCR over the last 6 months. You can clearly see the 2 peaks. One peak we know, which happened around 3rd week of June, where at one time we had over 850, around 850 patients in our system. And the second peak, which we just probably we are over with that peak now, which happened in mid of September, where we crossed over 900 admissions at any given time. And this, I think, two peak reflection is what we have seen in large parts of the metros of the country. And below is an interesting graph where you see the ICU occupancy, and persistently it has remained in 20s. Just off late, the number of patients in ICU has crossed 30%. Next slide, please. Well, the recovery rate is something which is a very, very positive note. And starting from a low recovery rate, at Max Healthcare, we now have sustained a recovery rate for the last several weeks at 85% and above, which quite similarly parallels the national recovery rate of late 70s and early 80s. Next slide. And the good note is the progressive reduction in the fatality rate. And this is a cumulative of many things, including experience, the learning, new modalities of treatments coming in, the protocols getting better. We peaked at a fatality rate of about 8+%. And now we are down to under 6. And in some of our bigger hospitals, the mortality rates have been in 4 to 4.5%, which are, I would say, a good, impressive outcomes. Can I have next slide, please? Yeah. So this slide is again a very interesting phenomena which we are seeing, is that the number of patients who are now requiring ICU or ventilatory care has gone down. So we started with almost 30 to 35% of our patients requiring ventilator at the start of the outbreak, which has now come down to about 15 or 14%. And this is again a big learning, I would say, for us as physicians, is complete change concept from an early thought process that the patient should be put on a invasive ventilator, because non-invasive strategies should be avoided because they lead to a lot of aerosol generation and virus spread, to strategies now saying that invasive ventilator should be the last resort. And my subsequent studies and slides which confirm this fact, and now it's a known standard fact. So this slides actually beautifully reflects how the requirement and need for patients going on to invasive ventilator has come down by experiences and learning. Next slide, please. So these are, we collated data of initial 1,000 patients and some interesting observations. And I'd like to spend next few minutes talking about these, is that if you see at the age profile, and this age profile has consistently remained same for over 10,000 patients, so we can extrapolate this, is that about 45% of our admitted patients were less than 45 years of age. Between 45 to 60, we had 30% of patients. Between 60 to 75 years of age, we had 20% of patients, and above 75 years of age, less than 5%, with a male to female ratio of almost 60 to 40. And obviously, we know the common symptoms are fever, cough, fatigue, headache, breathlessness. So number of patients who had no symptom was about 10% or slightly less than that. And interestingly, if you see the number of comorbidities, there were over 50% of the patients who had who had zero comorbidity, and almost about 12% who had at least 3 or more comorbidities. And about 30% of the patients went into ICU, 17% required ventilator, and this is the earliest part of the study where the mortality rate was about 10%, which has now come down to 6% or below that. Next slide, please. So again, now breaking the mortality statistics on basis of age, we see that younger people less than 45, the overall mortality rate was just about 2%. Between the ages, now this is our most productive and the large population base, between 45 to 60 years, the mortality jumped to almost 10%, from 2% to 10%. And now further age group 60 to 75, the mortality jumped to 27%. And above 75, it jumped to 40%. And interestingly, old female, 75 above, had the highest mortality, which goes to almost 46%. So clearly and this is now known, that age prediction and slight gender prediction has a very important bearing on the outcomes. Next slide, please. Now, here the slide really says as to how the comorbidities had affected the outcomes in our group of patients. When I said the baseline mortality rate at the time when this particular study was undertaken in the initial part was 10%, people who had chronic cardiac disease, excluding hypertension, the mortality jumped to in excess of 30%. And people with chronic kidney disease to 50%, people with diabetes and macrovascular complications almost 38-40%, and those without complications 15%, and people with hypertension had 20% mortality. Next slide, please. So number of comorbidities, if you have no comorbidity, the mortality was less than 2%, whereas if the 3 comorbidities, it jumped up to 35%. Next slide, please. So same slide which depicts as the age goes by and the number of comorbidities increase, the mortality keeps increasing. Next. If a person requires oxygen, the mortality rates jump many fold, almost 10 to 15 folds. Next. So very interesting phenomena that the people who went on to ventilator, the mortality was in excess of 50%. And for the group which was on invasive ventilator, the mortality touched almost 80%. Whereas people on non-invasive ventilator, it was in 40% or so range. Next slide. Response to treatment. This is something which is an evolving field. I have a slide on convalescent plasma, which I'll talk about subsequently. You can go to the next one, please. Okay, so we were one of the first earliest centers in the country to start using convalescent plasma way back in April. Initially, we enrolled about 50 cases as a part of DCGI study. And from mid-June onwards, once ministry let it use it as off-label indication, of course, we have now had over 1,000 patients who are presently on plasma. And we have seen, and we are going to publish this soon, seen a positive outcome, especially in patients who have gone to ICU and have an increasing oxygen requirement. Plasma seems to be having a good role in such patients. Since my time is over, I'll just take one more minute to finish my subsequent slides. Can we skip to the next slide, please? So we have started doing telecalling of our patients after COVID because post-COVID is a real entity. And out of 1,200 cases which we have interviewed, we have seen about 40 to 50% of patients having some symptoms. Since the time is over, I'd like to just say that Max has played a big role in home care of COVID management, and a large chunk of our patients who are mildly or early symptomatic, we have successfully managed at home. Our labs have contributed to almost 70,000 plus laboratory tests. So overall, I think in terms of territory in the region of North NCR, Max has contributed in a big way in management of COVID. And we work shoulder to shoulder with the government agencies in trying to take care and play our role in COVID pandemic. Thank you.
Thank you, Dr. Budhiraj. It is very, very nice to see some very impressive clinical data. And I know that you have the experience of a large number of patients and very impressive in terms of your analytics as well. So thank you indeed.
Thank you.
I will now ask Vinay to deliver his talk. And unfortunately, we are really short of time for questions, but we'll see what we can do. Vinay, please.
Thank you, Dr. Jairam. My topic today is healthcare responses to 2-3 cities for COVID-19. I'll be talking very general on this issue. And I'll start by paying my respect and condolences to our medical force, that is doctors and paramedical staff. Till now, about 450 doctors have died. This slide speaks that out of them, 63% are general practitioners, and about 35% are specialists or junior doctors. 450 doctors have been martyred till date against COVID-19. 65% of those are general practitioners, and most of them are from type 2 and type 3 cities. This is an important observation. 72 out of these 450 doctors were of the less than 50 years, with 17 of them were as young as 35 years or below than that. Frontline active service doctors handling COVID pandemic across the states. These are those doctors who have been serving in as a frontline doctors in government setup predominantly. These unfortunate figures are reflective of our preparedness and response to COVID-19. For to neglect this and must take lessons from our future preparedness about epidemics and pandemics. Unless we take adequate steps to ensure our frontline healthcare workers with proper right care and resources, we cannot win this battle. And unfortunately, this is the most affected area is type 2 and type 3 cities. 80 to 90% of our healthcare in tier 2 and 3 cities is catered by private healthcare, small and mid-sized hospitals owned by doctors, coordinators, and with private sector by local and state authorities, bureaucrats by standard guidelines. Professional preparedness for management of pandemic, healthcare infrastructure, preparedness, planning COVID-19 hospitals. There are standalone COVID-19 hospitals, critical care beds and ventilators, and pooling of resources in COVID hospitals. Professional preparedness for management of pandemic, adequate supplies of PPE kits and other material, particularly key medicines, equipment, etc., testing infrastructure, labs, and other contact basics. And when I talk about preventive measures, that is the public education and awareness. My understanding on these issues says that all these three things are lacking when we talk about type 2 and type 3 hospitals. What actually has happened? See, if we really see, the entire management of this pandemic has been left in type 2 and type 3 cities by local authorities. And these local authorities are either district magistrates or the chief medical officers and other persons. And the time spent for in lockdown for preparedness practically went in managing the the labor and migrant labor which was going around. Instead of creating select COVID hospitals and pooling of resources, manpower, instead all small mid-sized hospitals were directed to create beds. Another unfortunate scene which has happened in these type 2 and type 3 cities, when the local administration asked them to admit COVID patients. And those 50-bedded hospitals, particularly in Delhi, also 20% beds were reserved for COVID hospitals. And there was hardly any place for segregating COVID and non-COVID patients, and which practically became so difficult for these hospitals to be managed. And in many places in these districts, doctors were blamed for the spread of COVID. They were challaned. At one place, doctor was arrested. And various authorities, particularly civic authorities, took explanations from the doctors and the medical nursing homes. The nursing homes were sealed. And in few places, even in Delhi, initially even RWAs in few areas reprimanded, misbehaved, manhandled healthcare workers doing COVID duties. I talked about random sealing of hospitals and closure of clinics, which was very, very, not scantily, but very, this thing happened in type 2 and type 3 cities. In some cases, even FIRs were filed against doctors. No resource mobilization planned in advance and no coordination was done between the local authorities, district authorities, and the state government. Shortage of protective equipment, leading to vulnerable healthcare workforce. Testing infrastructure and authorization of private labs to conduct tests was delayed, particularly at least for a month, leading to poor identification and contact tracing. Lately, even unscientific capping of charges and no support towards the other resources like EMIs and procurement, etc. Now, capping of charges, they affect mostly the small hospitals and nursing homes, particularly who are admitting this COVID patients. You have all seen increased incidence of violence against doctors, particularly if you take cities like Moradabad, if you take Indore, we take Guntur, we take Vijayawada, and even some parts of Delhi, this kind of increased incidence of violence against doctors because there was no proper coordination, no proper management of COVID, and no differentiation of COVID and non-COVID areas in various nursing homes, small nursing homes. Doctors and healthcare workers who lost their lives while performing their duties in COVID zones There was no financial assistance or was provided to them, or even insurance coverage which was provided by this government in the form of that Garib health course was also very scanty available. My take on this is, because time is short, that COVID-19 management is a very, very professional management thing. Success in pandemic management is possibly only by a proper coordination of medical bodies, state authorities, civic authorities, central government directives, and the public. Unless we all coordinate this entire movement, this kind of a pandemic is very, very difficult to manage. And with this word, I'll say thank you very much.
Thank you indeed, Dr. Vinay Agarwal, for being so frank and forthright. You're absolutely right. Unless we have the support of the government and unless we ensure that all bodies work together, we cannot function with efficiency. Your experience and your profound statement has immense value in the management of these cases. Thank you, sir. As I can see, we are already at 2:30, and therefore, with reluctance, I'm going to avoid any questions. I'm only going to request all speakers to actually switch on their video as the FICCI group would like a group photograph of all of us. And may I ask anybody in the audience to, if they have specific questions, to address them, who in turn will email the respective panelists and we'll be happy to answer them. On behalf of myself and Aarti as well as FICCI, I thank the panelists for their very, very appropriate messages, which will go a long way in helping strategize even further the management of this COVID-19 and other pandemics in the future. Thank you indeed.
wait. Chandan, please indicate when to start.
We are live.
Very good afternoon to everyone. I'm Dr. Aarti Verma, and I'm a member of FICCI Health Services Committee and working with Max Healthcare. It is an honor and privilege to convene this session on this very, very important topic as part of the HEAL conference organized by FICCI. Today's session is the second scientific session, and the theme is going to be the spectrum of clinical syndromes and complications. It is an honor to welcome all the delegates and all the esteemed colleagues and panelists on this show who have taken out their valuable time to share their experiences and knowledge with us. So I would, without further ado, I would like to introduce the chair of this session. He actually needs no introduction. He's a very, very well-respected and well-reputed person, Dr. B.K. Rao, who is the current chairman of NABH, and he's also the chairman of Department of Critical Care and Emergency Medicine, Sir Gangaram Hospital. Dr. B.K. Rao is a renowned intensivist and a Padma Bhushan awardee, very, very richly deserved, sir. He started his career as a consultant anesthesiologist in Sir Gangaram Hospital and literally has grown with the hospital and contributed tremendously to its reputation and clinical governance systems. He is a member of the hospital's board of management from 1996, a very difficult and challenging role to play. He's a member of the board of governors of Medical Council of India, formerly. He's the former chairman of National Health Committee, ASSOCHAM. He is passionate about being a teacher, a guide, and a researcher in the field of critical care medicine, and has richly contributed to the scientific literature through his articles, chapters, and publications. So welcome, Dr. Rao. And I now request you to please chair the session and introduce the speakers and take this forward.
Dr. Aarti, thank you very much for your kind introduction. Delegates, my co-speakers, a very warm welcome on a warm afternoon today. We have, it's a very pleasant duty for me to introduce the speakers. We have 5 speakers with us, all renowned in their own field, all having extensive experience in the COVID management. I've been involved in the COVID management right from day one, which was the late March this year. The first speaker that we have will be Dr. Neeraj Jain. Dr. Neeraj Jain is the chairman and senior consultant departments of chest medicine, Sir Gangaram Hospital. Dr. Jain is a renowned chest physician in the country, and I know all the VVIPs want him and his opinion. I have a personal experience of that. He has more than 3 decades of experience in the field, including his initial training at Charing Cross Hospital, London. He is an expert in interventional pulmonology and sleep-related breathing disorders. Dr. Jain's special interests include bronchial asthma, pulmonary tuberculosis, sleep disorders, chronic obstructive and critical care. Dr. Jain has been very, very passionate about COVID-19, and he handles them both at the beginning when they come to the flu clinic or the fever clinic, and then kind of stays with them till the time the eventual outcome is there. We have the next speaker. Can I have the next slide, please? Yeah. So deviating from the adult scenario, which Dr. Neeraj Jain will be taking up, we have a lot of questions about, the children and the adolescent. Are they same? Are they different? Is COVID the same between them, between the children and the adults, and a lot of other issues. And to discuss that, we have another very distinguished pediatrician who also has specialized in the infectious disease, and she is currently working at the KDA Hospital and Medical Research Institute, Mumbai. Dr. Tanu is associated with the antimicrobial stewardship of the ICMR. And in fact, she is one of the group who has started antimicrobial stewardship. And Dr. Ram is also there, Dr. Rama Subramaniam, and I also joined with them. She's a technical expert in pediatric tuberculosis for the National Tuberculosis Control and Elimination Program, and also the executive board member of the Fungal Infectious Study Forum. She has trained in pediatrics at AIIMS, New Delhi, and infectious disease and international health at the London School of Hygiene and Tropical Medicine, London, UK. She acquired further expertise in pediatrics and infectious disease at Hinduja Hospital, Mumbai, between 2002 and 2008. She is associated with Kokilaben Hospital since its inception in January 2009 as a consultant in pediatrics and infectious disease. She has to her credit 2 books, 20 book chapters, 65 publications in indexed national and international journals, and several hundred guest lectures. Dr. Tanu is uniquely placed in this, arena of COVID because she specializes both in pediatrics as well as infectious disease. And today we will be hearing from her as to how and why the children differ from the adults as far as COVID is concerned. Next one, please. We have Dr. Anjan Trikha from Delhi, All India Institute. He is the professor of anesthesia, pain medicine, and critical care. Again, very deeply associated with the management of COVID care. And we all know All India Institute is one of the premier institutes which got involved in the COVID care until today, probably the largest center taking part in the COVID management in India. Dr. Trikha was elected as a faculty professor by Difficult Airways Society, DAS, from 2018 to 2023. He has been awarded several prestigious fellowships, including National Academy of Medical Sciences and Indian College of Anesthesiologists. He conferred the membership of the National Academy of Medical Sciences, MNAMS, 2015, and was nominated as president of Association of Obstetrics Anesthesia from 2010 to 2016. He is also the member of the educational editorial board of Journal of Anesthesiology, Clinical Pharmacology. He was nominated as the chairman of the committee for setting up curriculum for DM course in organ transplantation and critical care by the Medical Council of India, and Dr. Trikha, if I may add, by the National Board of Examination also. Previously, Dr. Trikha has worked as a full-time visiting consultant, specialist anesthetist for 2 years from 2001 to 2003 at Wellington Hospital, New Zealand, which is a tertiary care teaching hospital, and was invited by the Department of Anesthesia and Critical Care, School of Medicine, School of Medical Sciences, University Science, Malaysia, as a visiting faculty for their postgraduate teaching training program. Can we have the next slide, please? Dr. V. Ramasubramaniam in the field of antimicrobial stewardship, in the field of infectious diseases, doesn't need any introduction. He's been a key member in most of the initiatives that I know of, and very, very active, very, very supportive. And here also he's going to be talking about a very difficult topic, which causes a lot of confusion in the minds of a lot of people. Dr. Subramaniam is the infectious disease specialist to the Apollo Group, and he's based at Chennai. Dr. Rama Subramanian is a senior consultant at Department of Infectious Disease, Apollo Hospitals, and director of the Capstone Clinic, Chennai. He's a member of advisory panel to the government for COVID-19 management in the state. Dr. Rama Subramanian graduated from the Madras Medical College, and did his post-graduation in internal medicine from the prestigious Postgraduate Institute of Chandigarh in Chandigarh. He trained in infectious disease and HIV in the United Kingdom after getting his MRCP. He also obtained diploma in tropical medicine and hygiene from the London School of Tropical Medicine and in genitourinary medicine from the Society of Apothecaries, London. Can I have the next slide, please? COVID-19 is not only a medical issue. COVID-19 has a lot of individual socio and economic aspects. Isolation is playing havoc. We all know that we are through a challenging time, but it's not only the body which is challenged, it is the mind also which is challenged. And to deal with that, we have another distinguished speaker, Dr. Samir Parekh, who's the Director of Mental Health and Behavioral Sciences, Fortis Healthcare. Dr. Samir Parekh is an eminent psychiatrist and the Director of Department of Mental Health and Behavioral Sciences, Fortis Healthcare. He has done his graduation and post-graduation from Civil Hospital, Ahmedabad. He is one of the leading academic experts in the field of mental health and conducts training programs and courses for doctors, psychologists, and allied specialists, and has initiated several awareness campaigns for the community. He is a very established speaker in the field of clinical and community mental health and has been a speaker at the various national and international forums on mental health issues. Dr. Samir Parekh also has a prominent presence in the media with various columns in the newspapers and a presence on television channels and websites. He has played a key role in enhancing the image of mental health in the country, and his views are widely appreciated. So I'm sure with the 5 distinguished speakers that we have, they will not only give you the insight into their own topics, they will also give you their own personal experience, which they have felt during the COVID management in the last few months. Can I have my slides, please? That's me. Can I have my slides also?
Dr. Rao, just give me a second. I'll put it up from my end. Just give me a second.
All right.
I believe there is some bit of a technical this thing. So would you like to just, start sharing? In the meantime, I'll start, you know,
You
and
want me to share the slides
if you
from
could,
here?
would you be able to do that? If you could just give it a shot.
Ooh. No, I can't. Can I just, instead of the slides, can I just carry on? Kalika,
Yes,
can I
please.
carry
Yes,
on? I
please.
don't need the
Yes, please.
slides.
Sure. Please,
So
please.
a very warm welcome once again to all the delegates and all those who are listening to us. Every year, FICCI holds the HEAL conference, and I'm very, very happy that this year, realizing the importance of COVID-19, they have dedicated their conference to COVID. And the theme they have kept, the post-COVID healthcare world, the new beginning. It is something that is going to make people, a lot of people understand the nuances, the complete, as we call as the gamut of what COVID is all about. And they have given us a session, which is COVID-19 spectrum of clinical syndromes, complications. And I'm really very grateful on behalf of myself and all the speakers to FICCI for having given us this session to talk about. I have already introduced the speakers to you, and you will agree that very frankly, how the beginning starts is from a patient getting symptomatic. So the session that we are going to be talking about is about the beginning of COVID in the society, in the hospital, or any other location that you can think of. But how did it start? We all know that in the end of December, that is where from the Wuhan Medical Municipal Health Commission, it was reported that there was a viral pneumonia. They didn't know what was causing it. But very soon, by 9th January, they knew what was causing it, and they found out it was a novel coronavirus. And by the 11th February 2020, the disease was named as COVID-19 by WHO. And by the 11th of March, it was declared as a pandemic by the WHO. Initially, they were not sure what causes the transmission, but then gradually they realized how it was from human to human transmission. And that is what set the tone, the pace of the spread. If you look at 4th February 2020, by the 4th February, 99% of the patients were in China, and the rest of the world had just 176 patients. But the whole thing has changed. Now China is at one corner, and the rest of the world is where the COVID is. And if we look at the world today, we have 33 million patients of COVID, out of which 6 are in India. And China had just about 85,000 COVID patients. And if you look at the active patients, then we still have almost, China has only about 5,500 odd active cases, but the rest of the world has got something like 76 lakh or over 76 lakh patients. So what was the impact of that? For the whole world, everything closed down. Life came to a standstill, not only inside the hospital, but outside the hospital. And WHO had carried out a survey in the August of 2020, where they found that 90% of the countries have reported disruption in the essential medical health services. So COVID is something that needs to be managed and managed fast. And one of the things which is paramount is what we will be talking about, the symptoms and the complications. And I'm sure in the coming sessions, you will hear more about the other aspects, which is the diagnostic and the treatment and the vaccination. But to set the ball rolling, I have introduced the speakers. So let me call upon Dr. Neeraj Jain, who will be talking about the spectrum of clinical presentation of COVID-19 in adults. Dr. Neeraj, please.
Thank you, Dr. Rao, for your kind introduction, and thank you to all the organizers for allowing me to present my side of the story, so to say. My job is limited because I have to literally enumerate the various ways in which COVID is presenting to us nowadays. Our experience over the last 6 months from making a task force to try and organize the hospital, the OPDs, the inpatients, the ICUs, trying to see what protocols we wanted to put in place, including securing the PPEs, all that took a huge chunk of our time. And I'm proud to say that at Sir Gangaram Hospital, we got a very well-oiled system in place where, we have handled a large number of patients in a way that, people have gained that confidence now, including our own doctors. Now, the evolution of our learning about the virus is now kind of, I hope my presentation is visible.
Yes.
Okay. So in the last 6 months, what we've done is we've learned that COVID is not just a simple disease. If you'd asked me to talk about the clinical presentation of coronavirus 5 months ago, it would have taken 2 minutes because we thought that corona was a flu and, there were some flu-like symptoms and it could be dangerous. Now, this evolution process where we were here in Jan, Feb, March, where we knew virtually nothing about the novel coronavirus, to a rapid learning process. And today we are sitting in front of our technologies and, being able to communicate with the whole world. And trust me, it is this technology that has helped us learn. The sharing of knowledge all across the world is what has helped us learn faster as to what the coronavirus does. Very quickly, the clinical spectrum, I will not be able to go into details. I'm going to outline, how it can present. Let me take the worst case scenario. Some people will present directly with multi-organ failure, sepsis, septic shock, and these people do very poorly in terms of outcome. A sizable number will present with respiratory failure of varying degrees. Some will require to go to the ICU and require mechanical ventilatory support. A lot of them will require lots of oxygen, but will make a recovery subsequent to that. Fortunately, most of our patients are in this group. And the asymptomatics and the polysymptomatics make up the huge chunk of the patients that we see. And that is the only encouraging thing so far. That trend, I don't think has changed so far. I think right from day one, we are seeing that most patients will present with minimal symptoms or no symptoms and recover. Someone will say, why include asymptomatics as clinical presentation? They are a very important part of our clinical presentation. You have people who come into the hospital for other issues with no symptoms of COVID and are diagnosed to be COVID positive. Then you have people who just out of fear of having had COVID or, they think they've come in contact with somebody, they will get tested. Plus we have a community testing. Some people, some places will be doing large scale community testing. So this is a huge number. Don't forget the incubation period for this disease typically is like 4 to 6 days with a range of 1 to 11 days, which is like the other coronaviruses that cause SARS or MERS. So it is behaving in a similar fashion. Now, some of these asymptomatics may go on to develop symptoms. Some of them will remain asymptomatic. There have been large number of studies to try and find out the incidence of the asymptomatics. This classical example is that cruise liner, which was forcibly quarantined at sea, and it served as a cohort where 3,600 incidental involuntary actors in a well-controlled trial, more than 700 of these became infected. But when they actually analyzed the data later, the true asymptomatics in this population was about 18%. Since then, we've had multiple estimates which put these figures at 20 to 40%. But I think with the more seroprevalence studies, this will go on changing. This figure will go on changing. Coming to what are the symptomatic patients and how do they present to us? Again, going back to Feb, March, we all felt this was like any other flu, where people would come with fever, cough, breathlessness, maybe a runny nose, sinusitis, and it would be indistinguishable from the classical influenza illness. It is true, still most people who are symptomatic will have fever, cough. This cough is usually a dry cough. It's more of a throat irritation or a pharyngitis. Of course, there is a bronchitis, but productive cough incidence is very low because one, it affects the throat or the pharynx or the upper respiratory tract, and in the lungs, it affects mainly the smaller airways and the interstitium. So the productive nature of the cough is not there in these people. Dyspnea is present in 20 to 45% of the patients that we see. So these are the common respiratory symptoms, apart from the others, which you can have variable degrees of nasal stuffiness and so on. Then as we went on seeing more patients, we realized that the musculoskeletal symptoms were actually very, very prominent in a lot of these patients. So myalgias, headache, and fatigue. And all of us who've been seeing these patients will realize that patients recover, they go home, but the muscle pains and the fatigue and the headaches can remain for a few days to a few weeks and take a lot of time to recover. And this may be the only presenting symptom also, that people come in with severe headaches, myalgias, and fatigue without any documented fever. Then the GI manifestations, the gastrointestinal manifestations, are not uncommon. You can have people presenting with diarrhea or vomiting or pain in the abdomen, and they may not have respiratory symptoms when they present to the hospital. Anosmia is now the most understood term, in my opinion. The general public knows loss of sense of smell is a symptom that they associate with COVID. So much so, some people will come and say, Doc, I have fever, but I have no loss of sense of smell. So maybe I don't have COVID, right? But the reverse is definitely true, I think. If you have fever and you have loss of sense of smell, it is very likely that you have COVID in today's day and age. So loss of sense of smell and loss of taste are two common symptoms that we see now. Coming to thrombosis and embolism. Now, this is a dreaded way of presenting. Some people will come in with severe chest pain, breathlessness, or leg swelling, and you find out that they have a deep vein thrombosis or with pulmonary embolism, or even without a deep vein thrombosis, they have a pulmonary embolism, which causes severe respiratory failure and can be life-threatening. Now, it's important to keep this in mind when a patient comes who's very sick, that this is a complication or a presenting feature of patients with COVID and has to be tackled as an emergency. I think this particular presenting symptom is to be underlined and to be taken seriously. The list goes on. Like I said, 6 months ago, I could have finished the presenting clinical symptoms in about 2 minutes. Now we know that you have dermatological manifestations in forms of urticaria or maculopapular rashes, even pustules that can form. Kidneys, acute kidney injury resulting in renal failure in somebody who has no pre-existing renal disease is a presenting feature of COVID too, and these patients may need dialysis for this. Hepatitis, rise in the liver enzymes, which may be symptomatic or asymptomatic, can be another way that some of these people present. And then you have ocular manifestations. So you have people coming with conjunctivitis, coming with massively swollen red eyes. And if you actually do the test, the PCR can be positive even from the conjunctival fluids. I've left the atypical as a blank thing now, because I'm sure 3 months on, we will have some more symptoms which are not typical of any other illness, but which COVID is causing. The virus is here, it's not going anywhere. These two are like the last but not the least. These are serious ways of, in which COVID can present. Neurologically, you can have strokes, seizures, polyneuritis, and the Guillain-Barré syndrome. We've had a few patients who've presented with fever and the Guillain-Barré syndrome, where you have severe weakness and paralysis of all four limbs. You can go into respiratory distress, you can go into urinary retention, and this is all due to the COVID. It's not an unrelated complication. Cardiovascular, I'm sure all of us have seen the acute COVID-related cardiovascular syndrome, where it mimics an MI. There is no anatomical obstruction of the coronary arteries, but yet these people will behave like an acute coronary syndrome. Now, if you look at this whole plethora of presentations, this virus has not spared any system whatsoever. This is just a summary where you have different, we classify this into asymptomatic, mild, moderate, severe infection, or critical infection. And a patient can present with any of these stages. It's not necessary that the patient has to start from mild or asymptomatic. And all of us clinicians need to recognize that we have to keep an open mind, and COVID can be a cause of a lot of the issues that we are seeing. I'm going to just end by this. I think part of the idea of these kind of symposia or meetings is that we take home some messages and try and see if there's any positive outcomes from this. We realize that we have to pool our knowledge, we have to move together in the whole world. And that is the only way forward to tackle this. If we were all doing our own thing and there was no international kind of agreement, then maybe we would be facing a bigger problem. During the lockout times, we've all seen what it did to our environment. It shows that we can care for our environment and we can clean it up in this country, provided we take a little bit of care. So maybe we should try and continue that effort. We are all equally vulnerable. Nobody is protected from COVID. Whether you're rich, poor, race, caste, everybody is equally vulnerable. Now, if we continue what we've learned in terms of hygiene, we may help prevent spread of other deadly diseases, especially tuberculosis in our country. Wearing masks, cough hygiene, it may actually go a long way. And the lessons that this virus is continuing to teach us in terms of lives being lost and the economies being hit, let's still keep working together. Let's get together and try and prevent any more damage from occurring in this. So with that, I would end my brief outline of the clinical presentations. I'm sure there'll be, lots of people talking about what else this virus does. Thank you.
Dr. Neeraj, thank you very much for bringing clarity to the conundrum of symptoms. And to a layman, they don't understand the various permutation and combination of the symptoms. So it is important for them to really have high suspicion index and then go to a hospital, take help, and go to the specialist who can then decide whether they have it or they don't have it. That would be one of the messages that we will be taking up the question and answer sessions after the all the 5 presentations, and then we can also have a discussion between our own specialists in case there is a question where we all need to address that. And now I would like to invite Dr. Tanu Singhal, who will be speaking on COVID-19 in children, clearly different from adults. Dr. Tanu, you can take over, please.
Hello, a very good afternoon to all. I hope my screen is visible.
Yes.
Okay, thank you. I would first like to thank Dr. Rao and FICCI for inviting me to share my view about COVID in children. And actually, I'm fortunate that I'm a pediatrician. I'm also a mother, and children fare better than adults, definitely, because they are less affected. In fact, less than 5% of the total cases of COVID in the world are in children below 18 years. And this can be due to multiple reasons. One is because there is less exposure, because right from the beginning, schools and daycare centers closed down, so children are at home. And also, children are less susceptible to infection. And there is a recent meta-analysis published in JAMA which showed that the susceptibility of children to get infected was about 50% that of adults. And also, some of these figures may be biased because children are also less likely to be tested because they may be asymptomatic, they may be mildly symptomatic. And also, if parents are positive and the child is sick, it is assumed that the child has COVID, and therefore the child is not tested and doesn't contribute to the case burden. Apart from the fact that they are less affected, even if they are affected, they have less severe disease. And this is the experience all over the world, including India, that they have lower rates of admission to the ward and ICU. They have lower mortality. In fact, the case fatality rate in children may be as low as 0.15% versus 3 to 5% in adults. And all over the world, since the beginning of the pandemic, there have been a few thousand deaths in children as compared to 1 million in adults. And I was just looking at Indian data, and as of now, there are only 400 deaths reported in children vis-a-vis 95,000 in adults. So the question which would be there in everybody's mind is that why do children fare better? And I think there are multiple reasons, but one of them is that the ACE receptors which are there in children are immature and the virus cannot get foothold inside the cell. Children have better immunity because of previous viral infections, including infection with the other commonly circulating coronaviruses. Immunity due to vaccination, while there is still some controversy about whether BCG and MMR really protect against COVID, it is believed that some of the better response in children is because they have recently been given these vaccines which stimulate the immune system. As all of us know, children have higher lymphocyte numbers, so they are better suited to protect themselves. Also, children have fewer comorbidities like hypertension, diabetes, chronic lung disease, which are common in adults and are contributory to bad outcomes. And of course, children have healthier lungs. There is no smoking, etc. So that is why children actually fare better. Now, there is another question in the minds of people is what about children and transmission of COVID-19? So while children don't suffer themselves, are they going to be like super spreaders who will get infected, be asymptomatic and spread the infection amongst others? And there were some studies which showed that children below the age of 5 years had higher viral loads as compared to older children and adults. But when you go to actual studies looking at secondary transmission from children, most studies from Australia, South Korea, Singapore, etc., point out that children are less likely to transmit infection even if they are infected. But I think the question has bearing to the opening of schools. So, I mean, while many countries have opened schools, I think in India, as of now, the time hasn't come to send children to school because the healthcare system is already overburdened, and these children would contribute to the case burden and also transmit infection to other people in their homes, even though they are less likely to do so. Dr. Neeraj already spoke about the clinical presentation in adults, and I'm just going to talk about how it is different in children. First of all, the rates of asymptomatic disease in children are higher. Usually they have mild symptoms like fever and cough. GI manifestations like nausea, diarrhea may be common. Systemic symptoms like headache, myalgia are less. And studies have not reported really anosmia and agusia in children. However, it may be because children may not be able to report these symptoms well. Skin rashes are common, and this is a picture of chilblains, which is seen as a manifestation of COVID in certain people. And even if severe disease occurs in children, it is either in infants or those who have other comorbidities like extreme obesity, congenital heart disease, etc. And apart from that, we will be talking about the pediatric multisystem inflammatory syndrome a little later, which is a distinct entity in children. As far as diagnosis is concerned, the usual principles apply, and the gold standard is the RT-PCR in the nasopharynx. The sensitivity is between 30 to 50%, so a negative swab does not rule out COVID. Unlike adults, where CT scans are commonly done for diagnosis of COVID, in children, these are not routinely recommended because CT changes are mild, they are non-specific, and it involves radiation risk, and children need to be sedated. And also, it is found that lymphopenia in children is much less common as compared to adults. As far as treatment of COVID in children is concerned, it is basically symptomatic and supportive because, as I said, that children have mild disease, so you isolate these children at home with their parents, and you give paracetamol and maybe some cough syrups. And actually, there is no role of giving hydroxychloroquine, azithromycin, ivermectin, or doxycycline in children for treatment. And while favipiravir is being used in adults, it is not approved for children below the age of 18 years. As far as children with severe disease is concerned, they have to be treated on the basis of whatever data is available from adult studies, and one might want to use remdesivir and steroids for this population. Coming to this condition called pediatric multisystem inflammatory syndrome, which has been talked about in the lay media quite a bit, it is actually a post-infectious syndrome following COVID, occurring 2 to 3 weeks after infection, and it has been described from Europe, USA, and from India. We have had experience with 4 or 5 children with PIMS at our hospital. Basically, these children present with a febrile illness, with a rash, and often they are very sick with low blood pressures. It mimics Kawasaki disease, which is again a medium vessel vasculitis or sometimes toxic shock syndrome. And what is important is that the disease has a varying severity spectrum. So you can have children who have mild fever and rash, and on the other hand of the spectrum, you can have children who come to you in refractory shock. These children usually have high inflammatory markers, and echo shows reduced ejection fraction and coronary artery dilatation. Many times the nasopharyngeal swab is negative because it's a post-infectious syndrome, but COVID antibodies are positive. And these children should be treated in well-equipped critical care units, at least the ones who have severe disease, and they respond well to IVIG, steroids, aspirin, and supportive care. So while these children come in very sick, if they are managed well, most of them actually have good outcomes with no sequelae, and the mortality rate in PIMS is actually less than 5%. And this is just to show you some photographs of a few children we've had. So this was a boy who was just having mild fever for 2 weeks. And he just had, along with this, little bit of redness of the eyes and this kind of urticarial rash on his body. And this was, on the other hand, this was a girl who came to us with fever and this kind of rash. And she went into shock a couple of days after coming, and she had very, very high, cardiac enzymes as well as TROP and pro-BNP. So basically, these are two kinds of spectrum of PIMS, and this girl actually had to be treated with IVIG, steroids, tocilizumab, aspirin, and inotropes, etc. So I mean, the disease can be of varying severity. Last but not the least, we have to talk about COVID in the newborn. So something which is good is that intrauterine transmission of COVID from mother to baby is very rare because most of these people don't have viremia. And even if the mother is infected, postnatal transmission from the mother to baby is less than 10%. And even if the baby gets infected, symptoms are usually mild. One would think that, newborns, if they get infected with COVID, they would have severe problems, but that's not the case. And that is the basis for the current recommendations that if a mother delivers who has COVID, the baby should be kept with the mother and breastfeeding has to be continued and the routine vaccines given. So as you can see from my presentation that COVID is actually a mild illness in children as compared to what you're seeing in adults. But we should not forget the indirect effects of COVID on children. And there are so many mental health issues which are coming up because children are in lockdown for 6 months. There is a learning crisis, especially in children who are going to public schools and government schools because they don't have access to online learning like private school children have. Children are at risk for abuse because the parents are at home all the time and they may be taking out their frustrations. And many people are not bringing their children to hospitals for vaccinations, which is leading to missed vaccination and rise in vaccine preventable diseases. And then finally, the indirect impact of COVID on children because of parents losing jobs and slowing of the economy. So these are much more than the direct effects. So finally, to summarize, I would say that COVID-19 is a mild disease in children and newborn. And as of now, the role of children in contributing to spread of COVID is uncertain. Treatment is mainly supportive, and we must always remember this entity of pediatric multisystem inflammatory syndrome. and the indirect effects of COVID on children overshadow the direct effects. Thank you.
Thank you, Dr. Tanu. I'm sure your talk will bring a lot of comfort and lot of take away a lot of anxiety that the parents have towards their children. It sets the tone for the clarity that children are different, they are not adults. And the disease in children is not that bad compared to the adults. No doubt children suffer along with their parents, because I think every member of the society is suffering in COVID-19. Now I invite Dr. Anjan Trikha. Dr. Anjan has been involved in the care, as I said earlier. And what he will be talking about is largely about that when patients go to the hospital, they may be from the spectrum of mild to severe. After all, what is it that decides whether they will remain mild or they will progress to a severe disease? And what are the complications that may ensue during the course of the treatment? Dr. Anjan, please. Dr. Anjan, please continue. We can't hear you.
Hello, can you hear me now?
Yeah, now we can hear you.
Okay, thank you very much, Dr. Rao. And you can see my slides. I will take you through the journey of a patient presenting to us and what really happens to him. He goes home or he goes somewhere else, and what do we actually do? Since the month of March to the end of September, we would have seen about 5,000 odd cases of COVID. And we have a dedicated COVID center whose medical management I had. And we've seen all possible various syndromes and presentations, and I've had some good results and also some bad results. Okay, most of the time when these patients present to the ED, they would be either as cases of SARI or ILI, and in our ED they would be awaiting test reports. That would be one group of patients who present to us. The other group would be diagnosed patients of COVID who would be coming from their houses, wherever they have been tested positive, or they could be referred to us from various other hospitals. We at AIIMS cater to a large number of patients coming from other government hospitals, private hospitals, and of late, ever since the lockdown has opened. As far as Patna, even yesterday, we've had 4 patients coming from Patna in 2 ambulances. Patna, Bareilly, Kanpur, Lucknow, they all coming from that areas. But when they come to us in the ED, they, if they have not tested positive, they are taken, they are kept in the ED. They wait there, and they are tested again, RT-PCR, and then if they are positive, they are after assessment, a triaging takes place. Either they go to a COVID area or to a non-COVID area. What is important is that since the 1st of April, we had our first patient on 2nd of April. We also have a suspect area which caters to a lot of patients who have tested negative at time 0, but have clinically, they are very suspect. So we keep them there and then we test them again. And by the time they are waiting in ED, they tend to have their ultrasounds done, if possible, blood biochemistry. And what is important here is that if they are not doing well on saturations, we try to prone them. And now it has been proven that the proning, conscious proning, should start as early as in the ED while they are waiting. Another thing which has changed over the last 6-8 months is the guidelines. We were supposed to admit all positive patients. Now we are not supposed to admit all positive patients. There was a time, the last time I had about 230 patients. Today I have 234 patients with me. The last time it was 230 odd patients. There were about 100 of them were walking around in the wards because they were positive, and as per the guidelines, we had to admit all positive patients. But now the things have changed. Asymptomatic patients are sent home. only the mild, moderate, and severe we are trying to work around with. They could be sent to a COVID care center. Initially we had our own COVID care center, which was at Jhajjar. AIMS Jhajjar has a cancer center which was converted to it, COVID center, but now we have changed into a proper COVID center again because the number of people have gone up. Or alternately, if they were moderate or severe, they would come to our COVID center, which was ideally initially a trauma center, which has now been converted to a COVID center with 4 ICUs and 3 floors of HDUs and wards. All the areas, the COVID care center or our places would have facilities for dialysis and some kind of ventilatory care. At the triage at the ED, these are the 2-3 things we follow. If the patient is positive, needs some oxygen, he goes to a COVID center. That means he cannot be sent home, he is admitted. If he is negative, he is on oxygen, he goes to a non-COVID area, depending upon the problem he has, cardiology, neurology, neurosurgery, GE medicine, GE surgery, whatever. But then we admit all patients who are moderate, have severe disease, or who are positive with comorbidities. This is a subset which is increasing as far as the last 2 months are concerned. We are seeing more patients with comorbidities, malignancy, CKDs, all possible comorbidities, especially the CKD and the malignancy number of patients have gone up. So while we are shifting, or once they have shifted, these are the things we do. We do the basic blood chemistry. The patient will have to go through that. And we do X-rays at the ED. But HRCTs, we don't do as a routine in all because of logistical issues. Once they are admitted to a COVID center, that is my center, they are again triaged at the ground floor. We have a single entry and a single exit facility for COVID patients. So they don't interact or they don't come in contact with anything else. So at that place, they are again triaged and somebody decides, depending upon the comorbidities or oxygen needs or hemodynamics, when they're shifted on from ambulances, whether they go to an ICU or the ward. And once they are admitted, they undergo the basic investigations and radiology. And because of ultrasounds being so easily available at every possible place, they would have repeated ultrasounds and also an echo along with that. The basic treatment, what this patient will get, would depend upon the guidelines prevailing at that time. I must say that the guidelines have been changing. We started from something else. We started with azithromycin. Now we use doxycycline. Initially, we were using a lot of hydroxychloroquine. Well, its use has gone down, though ICMR and the government of India and AIMS per se New Delhi hasn't changed its uses of HCQ. What is important is that most of these patients would be on oxygen, would be on various modalities to give oxygen, and they would vary from nasal cannulas with low flows to high flow nasal cannulas with about 60 liters flow with FiO2 of 0.8 or 0.9, and even NIVs with various kinds of interfaces. What we have realized that most of the patients can get away with the problem if they are cooperative and they agree to conscious proning. However, if they fail, and this may take a couple of hours or maybe a couple of days, they will have to be intubated and ventilated. And then it is a norm with us that most of the patients who will be hypoxic after intubation and ventilation, they would be proned. They would ideally have a proning session of about 12 to 16 hours at a given time. And it's not uncommon to see in an ICU of about 14 beds, at least 8 of them would be proned. We, as a protocol now, this has again changed over the last 6 months. We would be very comfortable using muscle relaxants in these patients who are prone. Initially, we tried using a lot of sedation, all possible types of sedative drugs in higher doses. But because of intense coughing which they had, and we had a couple of issues of patients getting accidentally extubated in prone positions, and then a chaos happened. So for 12 to 16 hours, they would be on bolus doses of muscle relaxants so that we don't have any accidents. In principle, again, though it is world over, it is on that you could feed these patients, give them NG feeds per hour, whatever the rate you gave as per your protocols of the ICU, we would avoid using NG feeds, and we will not prone a patient if he is hemodynamically unstable on large volume or large doses of inotropes. We have changed our practice of management in COVID patients primarily because of two things. One is the healthcare worker, and the other is the non-availability of enough of resident staff. So that's why we try to play safe. We have been able to rope in nurses from various other departments, residents from various other departments. It would not be uncommon to have a team of 5 people for 20-bed ICU, where the last person is from the department, a junior resident from the department of pathology or biochemistry. I think that's the way forward, because we thought we could rope in these guys, and that's why some protocols were changed by us, and the patients are managed with these changed protocols. Treatment is essentially, as has been mentioned earlier, the basic treatment would depend upon steroids, heparins, low molecular weight or unfractionated, and antiviral drugs. Remdesivir would be the one of choice. But many times now, a lot of usage of remdesivir is social pressure on us, social pressure from various other sources. We have a lot of mighty and powerful patients. They would insist to start remdesivir on day 1, and this is what the patient gets. We try to resist them. We try to stand by our protocols, and most of the times, I think we are able to convince the patients that it is no use to start drugs. It is no use to start steroids unless they are indicated. It is no use to start antiviral drug like remdesivir unless they are indicated. And let's be all very clear that remdesivir is not a silver bullet. Antibiotics would be used as per protocols. Now the second box has these 3 things. We were the first ones to start plasma usage, and that was a time when we didn't have kits to test antibodies neither in the recipients nor in the donors. Now we had that, and our personal experience is that it is really not, it doesn't really help us in getting the patients out of the ICU. It doesn't do that. So our usage of convalescent plasma has gone down remarkably, though in spite of the fact that we have a huge bank with us, we have a huge list of patients who are willing to come and give plasma to our own blood banks. And this is another modality where there's a lot of social pressure. There's a lot of social pressure for us to use plasma. And at times we have patients' relatives coming with plasma donors whom we have to refuse. The second group of drugs, which is again in fashion, has been used, right, at least in our country, went out of, was not available, was TCZ and ITZ. ITZ is from an Indian company. Tocilizumab was available from Cadila, and I hope each one of us is aware of the fact that the cost of TCZ went up to, in a black market, to about 1 lakh of rupees for a single vial of 400 milligrams. We have been using TCZ. We see, when we see a cytokine storm, we don't have any options left with us. We would use steroids. We would increase steroids to a dosage which is maximum 1.5 to 2 milligram per kg of methylprednisolone we used. And from day 0, we have been using methylprednisolone. That is as before the recovery trial came. And we've stuck with methylprednisolone, and we preferred not to change over to dexamethasone. The other drug, ITZ, the drug controller has allowed it, as so many other drugs, but we don't really use them because we have been part of the drug trial with atezolizumab, but we really think that it doesn't really work in patients as much as it has been projected across. The similar is as far as favipiravir is concerned. Other drugs which are used, and you will be surprised, we have been having EICU seminars at least twice a week for the last 10 weeks for whole of the country, about 15 to 20 medical establishment every day. And you will be surprised the kind of drugs which have been used. Colchicine, methylene blue. Somebody was using methylene blue by the nasal route. So I'm trying to mention these because the admitted patients in various parts could get these, but these are now totally off the label. And then we really try to discourage doctors from using them. As far as invasive ventilation is concerned, once the patient goes on a ventilator, then we all know that the outcome can be a bit of a problem. And the outcome totally changes if we can avoid that. So we need to ventilate them as per the aid ARDS net guidelines, everybody's aware of that. And these are some simple modes which we are using. APRP is a mode which is in fashion world over. I'm sure in the next 2 to 3 months, you'll get a lot of publications coming on ventilating these patients with the APRP mode. There was an issue about the use of high flow nasal cannulas, tracheostomies, percutaneous tracheostomies, because of the fear of generation of aerosols. That was in the month of April, early April, and maybe even early May. So now we have overcome that, just because our PPEs have become standardized, they are safe. We have been able to convince our healthcare workers that they are not exposed to anything. We have taken care of our health workers. So now tracheostomies and PCTs would happen as per a standard protocol. As a rule in our setup for the last 6 months, for 2,500 odd people in my center, we always have done an open tracheostomy. We've avoided doing percutaneous tracheostomies because we still have at times a lot of fogging issues, and our doctors were not comfortable doing that. So we shift the patient to the operation theater, which is at the same floor. A ENT surgeon comes, does a tracheostomy, and we come out. And we would, at the present time, for the last 2 months, we must be doing at least 1 tracheostomy a day along with other surgeries. And once a tracheostomy is done, patient is tried to be weaned. Even if it is not done, the weaning criteria as per standard protocol takes place and the patient gets discharged in due course of time. Now, what other thing happens? When a patient is admitted, we take care of these other things. Frequent investigations, cultures which are protocol based, antibiotics which are protocol based, changing of central lines, catheters protocol based. One has to go through all these things in an ICU setting. In a ward setting, when the patients are now sicker, we are converting our wards to kind of HDUs with high flow nasal cannulas, and these protocol based things will go on. And they would invariably be getting, the ICU people would be getting the diets as per their disease processes, high protein, renal diets, diabetic diets, and diabetes is another issue which we take care of. The admitted patients must realize in this COVID illness that relatives are really not allowed inside. This is one thing which is causing a lot of psychiatric problems. We've had problems with patients who had tried to commit suicide. We were all over the news because somebody jumped out of the window. So these psychiatric illnesses in these COVID patients are a bit of a problem. And I'm sure one of the lectures in the next one will put a lot of stress on this and tell us what it is all about. Another word about children and mothers who are admitted in with us. Well, we all know when the children get admitted, the mothers or the fathers or anybody or a caretaker comes along with that. So we had a big issue on this. If the child was positive, who would stay with the mother? And if the mother stays in a COVID area, if she's also given a PPE, so maybe she's not literate enough to undergo donning and doffing workshops to know what is done. A lot of brainstorming was carried out. So children who are in the ICU, who are a bit sick, no mother is along with them. But once they are in the ward or in the HDU, so we allow a mother to be inside. She is normally wearing an N95 mask, a gown and a cap and a glove, but she has to sign a legal document. She's aware of the fact that she's been exposed to a COVID atmosphere. She's willing to do that because of a child, and there's a distinct possibility that she become positive. Another thing which we've done for the last 5 months or so, we have a dedicated communication team, and every day, at least about, it was only about a month and a half ago that the government allowed getting video mobile phones inside, which were smartphones. But we have this communication teams with us from the month of first week of May, I think. We have about 5 consultants and 3 residents who are talking to those patients relative on the numbers they have given us. So from 1:30 p.m. to about 6 p.m., our communication team talks to them. And if somebody comes there, we have a provision of in-house video chats. These are the few complications which we've seen, and you realize that most of the times, some are typical sepsis, shock, VAP, multi-organ failure, thromboembolic complications. We thought we had them, we saw them earlier, but now with rampant use of anticoagulants, heparin, low molecular heparin, these incidences have come down. We are doing our own share of all patients who die after consenting undergo biopsies, minimal invasive biopsies of all the organs, and they also have a CT done at the end if they die off, so that we can have some database and know what is happening. We would have a dedicated 3 dialysis machine in our center, so acute kidney injury and chronic kidney injury will not be an issue. We've had a share of cerebrovascular accidents. We've lost some patients who bled in their brain, thalamic bleed, massive frontal bleed or frontotemporal bleed. We've had a share of this. And yes, somebody talked about conjunctivitis. One of our very, very important VVIP developed conjunctivitis, which was horrible. After we discharge these patients, there is a known, the problem has started because it's a new disease. We really don't know. They go back. They are still saturating at about 92, 93. We have started discharging patients on domiciliary oxygen. They need about 5 to 6 hours of oxygen when they go home, and they develop fibrosis, and we call them back and we may discharge them on certain antifibrosis drugs, but nobody really has good experience, and there's no robust data available from the world literature as to how to treat this post-COVID pulmonary fibrosis. There would be a lot of post-traumatic stress syndrome kind of a thing, which we'll have to deal. And I'm sure we are all trying to put emphasis nowadays on the acute part of it. The chronic problems will come. There were issues about whether these patients could develop malignancy as the time goes on, but we still really don't know. Lastly, we've had COVID operation rooms in my center where deliveries take place, normal deliveries, cesarean deliveries, pacemakers are being inserted, AEDs are being done now, routine intervention radiology has started. So gradually we have started accepting the fact that we're going to live with COVID. So it took some time for us to realize that, but it has come into us, and now we have started brainstorming how to get our postgraduates into the system so that the surgery residents learn surgery along with this COVID problem. The COVID research in the institute goes on. We would at any given time have about 150 research projects going on. I can assure you there is somebody doing research on the feces of COVID patients, somebody on tears of COVID patients, and somebody is also doing something on electron microscopy from the bowel sample. So we'll see a lot of these researches being published in the next 2 to 6 months. All researches will have to go through the ethical committee, and the consenting is very robust. Then really what happens? We'll have a group of patients who will die. And then what do? We in the institute are slightly different. We have been managing people who died, from arranging their relatives to be brought in, from arranging their funeral arrangements, depending upon the religion. There was a time when there was no slots available in Delhi city for the patients to be cremated. So that was all upon us. We were doing it. Our forensic medicine department was arranging everything, and we've had requests of arranging funerals at a specific cremation center, not in Punjabi Bagh, but at Lodi Road or something of that kind. So for our patients, we are taking care of them the moment they enter to us, and if they are unluckily, if they don't make it, we take care of them at the end of it also. To conclude, we must accept that nearly all mild and majority of moderate category patients would be discharged. 20 to 40 patients on ventilators would only be discharged. So we are looking at a mortality rate of anything from 60 to 85% patients who would be on ventilators and who will not really make it. If you come to our own data, we presented it recently of 1,026 patients till about the month of August. We had a mortality rate of about 75% of patients who were on ventilator, but we discounted patients who died within 24 hours because they were shifted from various ICUs. So we had a mortality rate of patients who were on a ventilator for varying length of time of about 64 to 65%, which was very acceptable and comparable from the data coming in from Italy or various other countries around the globe. Thank you very much.
Thank you, Dr. Anjan Prakash, for giving us a first-hand narration of what happens to a patient who enters the portals of a hospital, and also to highlighting the key events that take place as the patient moves on towards the completion of his stay in the hospital, whether it is a positive one or a negative one, and what differentiates as to whether the patient is going towards a discharge or a patient is going towards complications. But one thing you have said very well, that in India, not only we treat the patients, even the relatives and influential people keep deciphering the guidelines. And of course, I have seen that most of the time they are lagging in time. So they still stick to guideline which has been overruled and rewritten over. Anyway, they do help us and kind of cajole us to do a lot of things which they think will work. And so you have to use not only your medical expertise, you have to use a lot of tact also. So thank you very much. And now I invite Dr. Rama Subramanian, who's going to be talking about a difficult topic. You see, India is known for one of the countries with the largest consumption of antibiotics. We have some liking for antibiotics. For everything you can give antibiotics. And that was the pre-COVID time. And then came COVID. And now the antibiotics are being used. And Dr. Rama Subramanian is going to be talking about the secondary bacterial infection. So where, why, what, these kind of questions is what we are looking forward to hear from him. Dr. Rama Subramanian, that's a beautiful slide. Can you hear me or am I still muted? No?
Yeah. Thank you very much, Dr. Rao, for those kind words of introduction. And I would like to thank FICCI and Dr. Rao for inviting me for this program. I am starting with a very provocative photo here on the secondary bacterial infections in COVID. And you will see that the idea I want to convey is basically that secondary bacterial infections are hiding within COVID. It is very difficult to discern whether it is because of COVID or whether they are secondary infections which we need to treat the patient to improve prognosis. The issue of co-infections and secondary infections were recognized way back in 1918 during the Spanish influenza outbreak, when the predominant cause of death people realized was because of Streptococcus pneumoniae. Subsequently, during the 2009 H1N1 swine flu pandemic, it was more of MRSA infections, which were associated with complications and poor outcomes. And so on similar lines, people started looking for secondary infections and in fact giving antibiotics till they realized that secondary infections probably in most of the Western world were not as common as it happened with the flu. If you look at the pathogenesis and how the virus evolves during its stay in the human body, you'll see that the viral replication ceases by about 7 to 8 days in most cases and may prolong for a little longer in very severely ill patients. And most of the problems with multi-organ failure and sepsis like picture happens during the second week after day 10, when there is believed to be an immune dysregulation and a cytokine storm. So our approach to treatment also was based on this process. And so the initial period antiviral treatments were given and subsequently immunomodulatory agents were tried to control these complications. The initial evidence for secondary infections in these critically ill patients came from China. And one of the first papers said that the hospital-acquired infection rate was about 20%, and bacteremia also was significantly seen. But you have to understand that these were times when they were using a lot of immunomodulatory agents. And the secondary infection due to bacteria sitting in the lung or subsequently colonizing the lung typically happened between days 13 to 19, around the 2nd to 3rd week after hospitalization. That is the typical time when they picked up an infection which warranted antibiotic usage. It was also shown that secondary bacterial infection was revealed by the occurrence of a high CRP and procalcitonin in this study. In our experience, the CRP actually, after the initial increase which is seen with COVID, starts coming down, and secondary infections are more typified by the rise in white cell count and procalcitonin levels. The typical organisms which were shown in this study included strep pneumoniae and Klebsiella in the earlier part, and then subsequently Acinetobacter and other gram-negative bacteria subsequently. If you look at secondary bacterial infections in our context, in Indian practice, as Dr. Rao said, we are very happy to use a lot of antibiotics, and people, when the minute they have an upper respiratory symptom of cough or sore throat or headache, immediately start popping in azithromycin. It has become the standard of care. Even before they take paracetamol, they start using azithromycin, and it has been clearly shown with medical studies that azithromycin plays no role in the treatment of COVID. The second hurdle happens during the patient after admission when he comes with a severe pneumonia or a SARI and requires treatment. Even if the person has diagnosed and is positive for the PCR for SARS coronavirus 2, it is just in our culture to start on antibiotics. And most of us are prone to initiating antibiotics. It may vary anywhere from coamoxicillin, coamoxiclav to ceftriaxone to piperacillin tazobactam to meropenem. But because there is very precious little we can do for COVID, and there is a Murphy's law which states that the optimal management of a condition is inversely proportional to the number of articles coming in the journals regarding the treatment. And there is a hell of a lot of articles and various measures coming for COVID, but actually what matters or what makes a difference is nothing other than oxygen, symptomatic treatment with paracetamol, maybe antivirals like remdesivir, which is still not proven to make a huge difference in mortality, but of course, specifically the role of steroids and low molecular weight heparin. The third aspect is infection control. In a lot of situations, isolation and personal protective equipment, which is part of COVID management, impedes the normal process of infection control. So infection control is not optimal in most wards, and this results in increased bacterial infection. The use of steroids, even though it is not a great dose and even though it is not for long periods, most hospitals have their own customized way of steroids, whether it is dexamethasone or methylprednisolone, whether it is 6 milligrams or 10 milligrams or 16 milligrams of dexa, whether it is 40 or 60 or 80 of methylprednisolone. There is an immunosuppression associated with steroid use, and the use of tocilizumab was also shown to pave the way for not only bacterial infections, but a high number of fungal infections also. And lastly, the interventions done in the critical care unit, whether it is a central line placement, whether it's a tracheostomy, whether it's an intubation, leaves a lot to be desired with result when you look at the process of infection control. So all these have increased, and whether it is India or even several countries in the West, there has been a sudden increase in the occurrence of CLABSI or ventilator-associated pneumonias or urinary tract infections associated with both lapses in infection control and immunosuppression and probably excess use of antibiotics. But the most important is to understand or be aware of the diagnosis. If you see a red car with a horse, that's a Ferrari, but you need to know that this is not a Ferrari. So when you look at a person with COVID in your ICU who is deteriorating, we need to be able to identify whether the person is deteriorating because of COVID per se, whether it is a pulmonary embolism, whether it's a cardiac failure or pulmonary congestion, or it is an infection. So if you're looking at management of secondary bacterial infections, my points to stress would be that you need to ensure that infection control, because people tend to use less of hand hygiene when you wear a glove, and you can't be changing glove between each patient. So our use of hand hygiene is not optimal. There is probably a role of ivermectin, one dose, to prevent secondary infections due to strongyloides hyperinfection when we use steroids. This is open to discussion. We need to diagnose the secondary bacterial infections with probably a raising white cell count, procalcitonin, which may be elevated, and appropriate cultures sent before antibiotics are started. The choice of the antibiotic should be based on the local epidemiology and the resistance pattern. We need to limit immunomodulation. For example, no more than 10 days of steroids for most situations. Choose our use of tocilizumab because it definitely increases the risk of infection, and also limit the duration of therapy. So my take-home messages for you would be aware, keep your eyes open, ensure that we are able to diagnose our infections correctly, limit interventions, ensure appropriate infection controls are in place, and the 4 Ds, which basically mean choosing the right drug of the right dose, of the right duration, and de-escalation wherever it is indicated. So this is still the fundamental aspects of managing infections, and that is true for COVID also. I'm going to stop here, and then we can discuss the rest in the question answer session.
Thank you, Dr. Ramasubramanian. There are lots of challenges. One was that COVID is being taken care of in setups which have no microbiological background. They don't have their own labs. They rely on outside labs. I think the biggest collateral damage of COVID is through the antibiotics, because that is what has gone totally out of hand. And we are finding it very difficult to convince people not to use antibiotics and to use them rationally. So we will keep hammering this point over and over and over again. Dr. Ramasubramanian, you have to take that cudgel. So I suppose you have a tough task on hand. Each one of these speakers has talked about how challenging COVID is becoming for people to handle. It is causing a lot of psychological problems to the individuals. There are a lot of socio-economic also problems, and problems coming in because of the isolations and the quarantine. We have Dr. Samir Parekh, who is going to be talking about this very important aspect of COVID management, which is the impact of COVID-19 on mental health. Dr. Samir, you can start your presentation.
Thank you, sir. I feel as much, as less a doctor than one can ever feel when you are next to 5 solid clinical experts. And you can imagine my plight that I would have probably not understood 99% of things you said, except in the slide where actually mental health was mentioned. I sometimes even wonder, as my friends tell me, that had you even done your MBBS? So God bless all my teachers who passed me. But you know what? So I am going to speak and touch upon a few multiple topics and not purely clinical topics, because I think we need to understand that mental health is beyond the obvious clinical component. But I need to first start with what is most important, and that's why I mentioned that one feels overwhelmed by the kind of work that clinicians and frontline workers continue to do in a pandemic like this. It's just absolutely overwhelming. Some of my closest friends who work out of the daily ICUs and COVID wards, it's just unbelievable. For people like me to sit in a chamber and do teleconsults and within the frame of teleconsults and find teleconsults has been game-changing for mental health, and I'm glad that that happened. But I think it's remarkable. I just hope that this society is able to appreciate the most remarkable work that is done, and I do feel organizations, be it FICCI, all other associate organizations and industry bodies need to make sure that we showcase the work doctors have done for generations to come, because the dignity, respect, and stature of a healthcare provider, right, that needs to also be recognized and restored, which has gone through its own challenges, at least when it comes to the social space. And I think that's something that I really want to focus upon. I was asked a few weeks back by a journalist that, what is the impact on doctors' mental health in these times? And my answer to her was this, that I don't think this is the time to even evaluate it. It's like a person who's at war. A PTSD happens long after the war is done, because once you are in it, you are in it. And that's how it is. I hope that all of us understand the sheer impact that medical practitioners, clinicians, paramedical staff are going through, but the true impact on their mental health and their well-being is something that we realize much later, because right now it's the flow of the things. But I do feel all organizations, all healthcare providers need to ensure that at various levels, we continue to provide for various kinds of mental health supports for people working, and provide for platforms where engagement and interactions can take place. Because at the end of the day, doctors are as humans as anybody else is. To the other side, let's look at this from a social angle, because what is mental health? Mental health is a large social component. I mean, for most of you, you will be getting many more patients who will be worried about getting COVID without any signs of COVID, and worried about a lot of other things. And obviously Google and internet and social media has obviously become a whole different textbook, which has been written without any education or any background or any relevance, but which is far followed than anything else. What I have seen in the last 6 months, these 2-3 things which are happening. People who are anxious about getting the illness, people who are anxious about an uncertain future, people who are anxious about understanding and living and realigning, readjusting to the current situation, be it work from home, the new normal, and so on and so forth. I feel what has happened is that because we had a short lockdown and when we came out of it, our mindset was not able to change the way it should, given the fact that we are a heterogeneous, diverse, largely populated, densely populated society, that we are unable to ensure that everybody does what they are supposed to do. And I have been telling this to people, the only way to reduce anxiety of getting COVID is to look at precautions. Now the precautions, you have some campaigns on masks and then the masks go away, right? And the moment one person's mask goes away and you open up 2 public transports and the masks are not, importance of masks is not realized, it starts the whole vicious cycle. Then suddenly you get more people. We work so much with young people, and when you have young people going to a restaurant, clicking a picture with their friends and saying, oh, after a long time I finally got to visit a restaurant, you feel like telling them that you could have waited 3 months. Do the important things, do something that actually serves, but beyond this. But a lot of these things are happening. I've been talking to medical students, college students, school students, students who are going to go overseas, students, young people who were supposed to get a job, were going to start a job, people who were going to get their appraisal, people with EMIs. All of these people have been largely affected by the uncertainty of the economy and future, and we need to accept it. That yes, the uncertainty component is having a strong impact on our overall well-being. And third is adjusting and aligning to this whole work from home. There is a lot of digital usage that is happening. Our lifestyles change. The commonest symptom people are coming to me with is less sleep. I am sleeping less myself, and that's what I tell all my patients here. It's okay. Our physical activity is less, our mental activity is less. So of course you will sleep less. You have parents who come and talk to you. There is so much digital time happening with children, but if they don't have digital time, what will they do? They can't go out. Their studies is happening online. Their entertainment is happening online. So all of this actually has an impact on mental health. WHO has been talking about it. That are we sitting on another epidemic, which is going to be a mental health epidemic? We don't need it. We didn't need a COVID to realize this. Look at these statistics. 300 million people globally suffer from depression. 240 plus million suffer from anxiety. Suicide is the 8th highest killer for adults. 3rd highest killer for the adolescent population. 1 in 5 people will have a psychiatric disorder in their lifetime. Now, when you add the whole COVID component, you're looking at anxiety, post-traumatic, depression, self-harming, socioeconomic concerns, relationship concerns, marital issues. These are the concerns which are going to be governing and ruling the next few months to years, the mental health side of the clinical spectrum. We also have almost an 800% shortage of experts. I fundamentally believe that expertization of mental health is not the solution in India. We have to be very clear at all levels, mental health needs to be taken care of while we take care of patients and families. So whilst we do our stuff, which is the basic medicine, we also need to take out about 60, 80, 90 odd seconds to feel, is everybody fine at home? Are you guys taking care? Make sure you talk to each other. Very basic things. The difference between individuals and families who will come out of COVID without significant mental health concerns vis-a-vis who would is going to be in social support systems. Those who use this time to stay connected, talk to each other, unmute themselves, speak, interact, share, these people will actually end up coming on the other side of COVID a lot better. In fact, when I am getting patients who've just been diagnosed, I'm not giving them any medications. I'm telling them, let's wait it out. So we don't need to rush into an anti-anxiety. We don't need to rush into an SSRI. We don't need to treat the immediate reaction. We need to absorb it. Because we don't need to get into a cycle where they feel, okay, fine, I'm anxious, let me pop in a clonazepam, I'll be okay. And that becomes another vicious cycle. We don't need to do that. It's about reassurance. It's about lifestyle. It's about staying connected and stimulated. And that's how you work. The vulnerable populations, children, one needs to be a lot more careful. And that's what I've been telling parents. Ensure that you involve them in a lot of creativity and connect them. Geriatric population, very similar. because one is looking at lack of stimulation, more depressive problems, more sleep issues. That's what is happening. And over and above that, people who have substance use are also going through their own struggle. You put all of this together, that's mental health for you. So whether it is the mental health of the clinician and the frontline worker, whether it is the mental health in the social component of all that we do, or whether that is in the clinical component of the anxiety, depression, insomnia, substance abuse, what mental health requires is that at all level of medicine interface with people, the mental health component needs to be in some way together. But I just have one more thought, which I consider this as a food for thought, and this is more of me working in the field of social and community health than purely being as a psychiatrist. I feel that the medical fraternity needs to be out there on social media a lot more than what it is, because social media conversations are making a mess of mindsets and making a mess of awareness levels of people. The only solution is not telling people, "Wahan mat padho, don't read there." The only solution is opinion leaders like all of you need to have a presence on social media where people know this is where you get the right information. And I think that's something which is very important. And I would suggest FICCI especially take this initiative, right? Be active on social media, because there are a lot of young people, a lot of people who follow social media now for almost everything. And it's important that medical practitioners, colleagues, all of us need to actually utilize this space, because in years to come, the interface of well-being and social media is going to be so blurred that if we don't preempt it, we are not going to be able to do just. So that's my two piece. Feel free to comment, have any suggestions when the interaction mode happens. Thank you.
Dr. Samir, thank you very much. I'm sure your kind words will bring a lot of succor to a lot of people. But you raised two very important points. One, being Indian, we believe in the adage that there are no atheists in the foxhole. So we are all believers of God. So we know there is somebody out there who's going to help you besides the psychiatrist, besides your own fraternity. And the second point you raised, very important one, is that too many cooks will spoil the broth. And that's what is happening on the social media. So your points are well taken. I hope FICCI pays heed to that and become more proactive or bringing doctors of the social forum. The good point is that as we went on in the presentations, a lot of questions which were asked got answered during the presentation itself. Those which were not answered, we are running out of time. I understand that. And I will just pick up those where I think they were not answered. And one of them is whether a patient who has been given the treatment for COVID in the first trimester of pregnancy, should the pregnancy be continued? So any one of you can take that. Who's handled
So there is no data to suggest that COVID is teratogenic, So, so there would be no issue in terms of COVID-19 affecting the pregnancy. Of course, the issue of what drugs were used is the question. So I don't know what drugs were administered to the lady. But as of now, I don't think there would be any reason to, abort the pregnancy.
So out of all the drugs Dr. Anjan has mentioned, is there any drug which will specifically call for a termination of the pregnancy, Dr. Anjan?
See, all possible drugs which have been used are all, that none of the drug inserts will say they can be used in pregnancy or lactation, right? All of the drugs would say. So as such, the problem is that during the first trimester of pregnancy, many of the people coming to us have been given these drugs at a place where they are not even aware that they were pregnant, and all these were given. Except steroids and heparin, I think everything causes a problem. So we've had instances, as Dr. Singhal has said, you have to bring the patient on board and tell her that these drugs have been used. We don't have any experience whether they are teratogenic or not, and do you want to continue or not? You can't take a decision on that. You will have to tell them that remdesivir, we really don't know what will happen. We never used that drug all these 35 years of pregnancy. As an intensivist, we never used TCZ. They were only used by rheumatologists or connective tissue disorder patients. So that's why at this time, we are not there to comment upon pregnancy. First trimester, second trimester, all the drugs being given. Let's say at time 0 now the guidelines are doxycycline. We all know it causes the problem. Ivermectin, we really don't know what's going to happen with ivermectin, the kind of doses. The doses have changed from Uttar Pradesh to Haryana to Odisha to Kerala.
Sure, I think it's too short a time for us to answer, whether it has caused any teratogenic effect or not. Time will tell us in another maybe 3-4 months. The second question, Dr. Raman Subramanian, is very interesting. It is that if COVID is more prevalent in immunocompromised patients, then why give steroid, which is known to be an immunosuppressant? Your mic is muted.
The pathogenesis and the role of our approach to treatment is still not very clear. We believe that the initial part of the infection is because of viral replication and the damage it causes, and subsequently what progresses and complications results are probably immunological in nature. And based on this and what studies have shown us, we are tailoring our treatment to give antivirals in the first part of the illness, and then we are looking at immunomodulatory agents in the second part. But there is still lack of clarity with regard to, is this actually how it happens? Because in that situation, why is it that we still find that, elderly people, some of them even beyond the age of 80, are asymptomatic in their infections, when we believe that a lot of the problem is because of the Th2 responses and the cytokine storm. So I still feel that we are, and personally, anecdotally, I would say I find a lot of patients with CKD and post-transplant who do very well. They have very mild infections, especially dialysis patients. Patients on maintenance dialysis, every day, one person in the dialysis group is positive. And all of them are out for a few days and then back at dialysis. They are isolated for a few days. So I still believe that we don't know the depth of these diseases. We still don't know what we are doing. There is no specific agent which has been definitely shown to help. We have a long way to go.
Dr. Neeraj, you give a lot of flu vaccines. So one of the questions is, should a person take a flu vaccine, hoping that it will kind of make him immune to COVID?
Going by science, I don't think there is any logic in that. The flu vaccine will not protect against the coronavirus. The other issue is the flu vaccine, whether it should be taken in times of the pandemic. That is a question that a lot of my patients ask, because this is the time that they take the flu vaccine every year. And I have told all of them to go ahead and take the flu vaccine. But I am not aware of any data that says that the flu vaccine may protect against the coronavirus. The other issue, which Dr. Ramasubramanian was talking about, which came to our minds a few months ago, and we've tried to keep a track of it. Patients with SLE who've been taking HCQS, patients with sarcoid who've been taking HCQS for a long time. I have not seen, all the patients that we've been through in these last few months. I have not seen patients with, autoimmune disorders, for example, coming with very bad disease in large numbers. And, our hospitals have a large number of these patients. So I think there is a lot of information that we don't know yet. And like Dr. Ramasubramanian said, we need to keep a very close watch and see what happens. Steroids are definitely working in a selected population. They are lifesavers. There's no doubt about it. But I agree, the timing and the dosage and the duration has to be very carefully monitored.
Dr. Anjan Prakash, last question to you. For how long a person will remain infective?
See, this is a question which, if the Parliament was in session, I could assure you that this would have been discussed in the Parliament of India. And like the way Rajya Sabha goes on, maybe somebody would have torn the guidelines. If you go as per the guidelines, and we all know that, and we practice that, and I'll tell you when we break the practice also. If a patient is symptomatic at day 10 from the first symptom, and if his last 3 days have been without any symptoms, he may continue to shed dead virus in his nasal secretions, or you could have a positive test from the nasal swab or the oropharyngeal swab. That would only be dead virus. That is one thing. So after this, after 10 days, I call it a 10:3 rule. This is ICMR rule, Government of India rule, and AIIMS New Delhi rule. 10:3. Patient is non-infective. However, patients who are immunocompromised, patients who have HIV, patients who have transplant, and these are the 3 groups which the government mentions, and we follow that, they may continue to have a positive test and continue to be infective for a longer time. So these are the only patients whom you try to test before you send them home. After having said that, you had hint upon it, Dr. Rao, this social pressure to do testing. I think it has become as good as ordering a butter chicken on the phone. You could get a test done on the phone, right? You could ask somebody to come retest him. I have known people who got retested 5 times and they are still positive. I have known people who are now trying to find whether what are the level of antibodies available. So there is nothing, no rationale in getting tests done. So if a patient is positive, if he is asymptomatic, follow the 10:3 rule, he becomes negative. Lastly, I would like to point out, we've had some very powerful people who had to take the next of the kin by flights after they had died. So we already doing some research work, and this becomes socially very important. And I could tell you my results in another 2 months or so. When would a dead body of a patient who's died, he would become non-infective? Because we've had last rites being done without any mythological, kind of practices being followed in any religion. So it's a social issue. So we have, like I said, we have many research projects. One of my research projects is to test a patient who has died for X number of hours, because people don't turn up to take their bodies. When do they test negative? There is nothing available in the world literature. There is something available regarding flu virus about after 6 hours, the body becomes non-infective. So retesting is a big issue. We follow the 10:3 rule. However, you must realize that you can have a dead virus coming in the feces for about 3 to 4 months. If you do a colonoscopy, you could have a dead virus being, the material being tested and the thing becoming positive for about 6 to 9 months. So let us not go into that. Let us tell the people that once you are asymptomatic, once it is being 3 days you are asymptomatic, you are, if at all, shedding a dead virus, you will be non-infective. Maybe my statements change in another 4 weeks, like they have changed all these 6 months. Maybe we come out with new guidelines, but this is going to stay.
Sure, we are changing because the virus is changing. We are changing because now we know more than what we knew about this virus. And we also admit that we still don't know all about this virus. So the time is going to be giving us a lot of answers, a lot of questions that still remain unanswered as of today. I must thank all my speakers, Dr. Neeraj Jain, Dr. Tanu Singhal, Dr. Anjan Trikha, Dr. Rama Subramanian, and Dr. Samir Parekh, for bringing a lot of clarity on the topics that we addressed today. And I hope that the listeners and the audience on the other side have gained a lot of insight into this aspect of the disease. And as they hear now and connect with the other presentations on the diagnostic and the treatment part of it, they will get a full picture of what COVID is all about. So thank you very much, all my panelists, all my speakers, Dr. Neeraj Jain, Dr. Tanu Singhal, Dr. Anjan Trikha, Dr. Rama Subramaniam, and Dr. Parekh. And thank you, FICCI, thank you, Dr. Aarti and Malika, for an excellent opportunity given to us to bring in a lot of clarity on issues which are still in the realm of, maybe, maybe not. Thank you very much, Dr. Malika.
Thank you.
Malika and Dr. Aarti.
Thank you so much, Dr. Rao, and all the panelists. It's been a very enriching session. So, Malika?
Yes, thank you so